This meeting to order. Welcome to meeting number 117 of the House of Commons Standing Committee on Health. Before we begin, I'd like to ask all members and other in-person participants to consult the cards on the table for guidelines to prevent audio feedback incidents. Please take note of the following preventative measures in place to protect the health and safety of all participants, including the interpreters. Please use only the black approved earpiece. The former gray earpieces may no longer be used. Keep the earpiece away from your microphone, from all microphones at all times, and when you're not using your earpiece, place it face down on the sticker placed on the table for this purpose. Thank you all for your cooperation. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. As a result of those connection tests, one connection was unsatisfactory to be able to participate in the meeting. So we have a smaller witness panel than is contained in the notice of motion. Jessica Diniz from JDRF will not be with us on this panel. I have taken the executive decision of adding her to one of the later panels today, provided that we can come up with the right technology so that she can fully participate. Pursuant to the order of reference adopted by the House of Commons on May 22nd, 2024, the committee is commencing its study of Bill C-64, an act respecting pharmacare. As indicated in the memo that was sent out a couple of days ago, I would like to remind members that amendments to Bill C-64 must be submitted to the clerk of the committee by 4 o'clock today. It's important for members to note that pursuant to the order adopted by the House on May 22nd, 2024, the 4 p.m. deadline to submit amendments is firm. This means that any amendments submitted to the clerk after the deadline and any amendments moved from the floor during clause-by-clause consideration of the bill will not be considered by the committee. So I would like to, without further ado, welcome our panel of witnesses and thank them for their patience as we attempted to overcome our technical difficulties. We have with us today from the Canadian Association for Pharmacy Distribution Management, Angelique Berg, President and Chief Executive Officer, appearing by video conference. In the room with us, representing the Canadian Federation of Nurses Unions, Linda Silas, President. And also online for the Canadian Organization for Rare Disorders, Durhan Wong Rieger, President and CEO. Welcome to all of those who have joined us to help us out with Bill C-64. We're going to start with opening statements in the order that appears on the notice of meeting. So we're going to start with the Canadian Association for Pharmacy Distribution Management. Ms. Berg, welcome to the committee. You have the floor.
Thank you, Mr. Chair and members of the committee, and thank you for your attention today. I'm Angelique Berg, President and CEO at CAPTIM, the Canadian Association for Pharmacy Distribution Management. And CAPTIM is the nation's trade association for wholesale distributors that channel over 90% of the medicines our country consumes. With their trading partners, distributors form our efficient, accurate, and reliable supply chain that ensures physical access to medicines. So naturally, we support the aim of Bill C-64. We support both affordability and access in balance, and not at the expense of one or the other. Importantly, we recognize the enormous challenges that government and our citizenry face: slowed economic growth, regulatory overburden, healthcare system insufficiency, and the growing percentage of the population over 65. I mentioned these to tell you that we're aware of the broader context, and we stand with you in navigating solutions where we can be of value. To appreciate our comments relative to BC 64, I'll provide some basics about the supply chain, because we rarely think about how our medicines get to us just so long as they do. The supply chain begins with manufacturers who sell to distributors who then sell to pharmacies and hospitals. Purchases flow the opposite way, from pharmacies who buy from distributors who buy from manufacturers. Rounding out that supply chain are service providers to this core supply chain, like third-party logistics firms and transportation companies. The majority of Canada's pharmacy supply chain stakeholders are CAPTIM members. Distributors streamline orders and deliveries for 15,000 product SKUs between hundreds of manufacturers and over 12,000 points of dispensing over 9 million square kilometers, creating efficiencies that save the country over $1 billion annually. Their safety stock also provides short-term shortages buffer against drug shortages. The sector has over 30 distribution centers, all of which comply with at least 3 overarching acts, up to 7 different Health Canada licenses, and very high technology to meet the conditions of all of those. The sector has roughly 20,000 employees, experts in inventory turnover and secure and complex handling of all medications, and they are the backbone of our pharmacy supply chain. Our market is challenging. It's a controlled market where funding is limited, yet operating and regulatory costs are not. Distribution is largely funded as a factor of the listed drug prices. The lower the price, the less that's available to get medications to Canadians. Costs have increased at least 2.5 times faster than volumes in the last 5 to 10 years, with market forces and increasing regulation. The gap is estimated at over $100 million annually, and distributors have so far absorbed that through eliminating expenses to stay in business and with only minimal impact to Canadians. So assuming that it is striving for lower drug prices, we see that Bill C-64 has the potential to erode physical access and to exacerbate drug shortages. Because they run so efficiently, reduced funding means that distributors have few options left but to reduce services. Some examples, they could stop carrying money-losing products, which would be those of the lowest cost, reduce safety stock, which eliminates the buffer against shortages. They could reduce delivery frequency to high-cost regions or eliminate them altogether. So CAPTM members are understandably concerned about some of Bill C-64, generally about reduced drug pricing, and specifically about a restrictive national formulary that was addressed in last evening's panel and with bulk purchasing. Evidence suggests that these types of policies limit suppliers. When the government awards a contract to a single manufacturer, that firm effectively becomes a monopoly. So competitors have little incentive to stay in the market. Concentrated market power increases the risk of limited supply, and therein lies our concern. We recommend this policy change be approached with caution, that further regulatory burden be avoided, and time taken for consultation with all supply chain actors to uncover potentially unintended consequences so that Bill C-64's aims can be successful. And we don't have all the answers. We dearly wish that we did, but we are most willing to collaborate with government to find them, to ensure safe, secure, and timely physical access to medicines for all Canadians, and that's why we exist. Thank you on behalf of the CAPTM Board of Directors, and I welcome your questions.
Thank you, Ms. Berg. Next, on behalf of the Canadian Federation of Nurses Unions, Linda Silas. Ms. Silas, welcome to the committee. You have the floor.
Thank you, Chair. As mentioned, my name is Linda Silas, President of the Canadian Federation of Nurses Union. As a nurse, I don't have to do like Angela to explain what we do, but for CFNU, we're the largest nursing organization in Canada. We represent over 250,000 unionized nurses and nursing students working everywhere from home care, long-term care, community, and of course our acute. I'm so honored to finally speak to you today on a bill that's being considered a leading priority for nurses for many, many years. It is a step towards a universal pharmacare program. CFNU has commissioned numerous studies and polls over the years to help build the case for overwhelming merits of a public single-payer pharmacare program in the country. You will be hearing from Dr. Marc-André Gagnon later on today, who was the author of one of our first report. There's many reasons for nurses to support a public single-payer pharmacare program. The first is the positive health outcome it would bring to our patient, the equitable access it would provide to everyone in Canada, and the capacity would free up our healthcare system through avoidable hospital room visit and the costs related of non-adherence to prescription drugs. The later point is the critical point I have to talk about today is the health human resource crisis. Each quarter, we witness the number of nursing vacancy to rise to a record of heights across the country. Sadly, nurses are still working in our crippling system where we see patients unable to access their medication who really should be home, but they need to stay in our waiting room in our hospital beds just to take their medication. Members of Parliament, you have the power to change this today. We are thrilled to see Bill C-64 move ahead in the direction that Canada's nurses have long advocated for, and it is in sync with the recommendation of every major government study and commission on the matter, including the Advisory Council on the Implementation of a National Pharmacare Program in 2019. Ensuring universal access to contraceptive and diabetic medication and supply through a single payer and public system is usually significant improvement to our universal public healthcare system, and it marks a fundamental step towards a truly comprehensive and universal national pharmacare program. Every day, nurses see firsthand the consequence of failing to provide equitable and coverage for birth control and diabetic medication to our patients. From unwanted pregnancy to individuals who lack access to diabetic medication and supplies and end up in our hospital, from our children to our working Canadians. Patients divide their pills or go without to buy food, and this has to stop. Canada's nurses have lobbied parliamentarians like yourself for 30-plus years to move toward a universal national pharmacare program. And yes, it has to be single payer and public because that's what the evidence says is the best way to be fiscally responsible of our public dollars. And that's what Canadians expect of us, not to have our healthcare services stop at the visit of a doctor or nurse practitioner. Sadly, we see many voices out there to support the status quo. They say Canadians are adequately covered by a patchwork system in place and that a fill-in-the-gaps approach is the best way. Nurses are motivated by the great care we can provide in this country, and we say the best way to do that is through a universal public approach to prescription drugs. We urge you to follow 20 to 30 years of evidence and pushes ahead the passing of this bill and continue on the path of implementing a comprehensive universal national public single-payer pharmacare program. I stand proudly with all of you who will vote yes on Bill C-64. Merci.
Merci, Madame Silas. Next, the Canadian Organization for Rare Disorders, Dr. Duhan Wong Rieger, joining us via video conference. Welcome to the committee. Dr. Wong Rieger, you have the floor. You just need to unmute.
Apologies, we should have known better. Thank you. How long have we been doing this? Thank you very much, Honorable Chair, members of the Health Committee. Thank you for the opportunity to speak and to you today. My name is Durham Wong Rieger, and I am the President and CEO of the Canadian Organization for Rare Disorders. And I'm here to discuss Bill C-64 and, in part, its implications for the rare disease community in Canada. I'd like to start, though, with a few facts that paint a bleak picture for Canadians with rare diseases. You may know that rare diseases affect over 3 million Canadians, the majority of whom are children. While most rare diseases affect children, we are also knowing that there are a significant number of adult-onset rare conditions that are being diagnosed. Among the 7,000 known rare diseases, only 5% have an effective drug therapy. Unfortunately, 1 in 3 rare disease patients in Canada cannot access their treatments. In fact, only 60% of the treatments for rare disorders that are made available in Canada, and most get approved up to 6 years later than they do in the US or in Europe. And even after the treatments are approved in Canada, many patients continue to face immense hurdles and delays in accessing new treatments due to the challenges related to the evaluation and the funding of these medicines. So when there are effective available therapies, access can often be very challenging for patients, and as you may know, they vary from one province to the other. So as a result of these challenges, many patients experience an avoidable decline in functionality, and certainly many experience early death. In an effort to respond to these challenges, on March 22nd, 2023, the federal government announced measures in support of Canada's first ever rare disease drug strategy, including at this time $1.4 billion investment for provinces and territories to improve access and affordability of rare disease medicines. This money had already been promised half a decade ago as part of Budget 2019. However, it's now been over a year since the funding announcement, and not a single penny has been spent to help fund rare disease drugs. It's in this context, while court supports efforts to improve access to medicine for Canadians who need them, all Canadians, we're also concerned that the federal government has taken on another major commitment to fund a national pharmacare program when it hasn't even delivered on its promise to fund rare disease treatments, a promise that, as we said, was made over 5 years ago. Notably, Section 5 of today's Bill C-64 would commit the government to long-term funding, beginning with products for rare diseases. We have to say it's unconscionable and unethical and certainly really, of course, on rare diseases. What does that say in terms of prospects for success of this pharmacare legislation? We need to see the prioritization for rare diseases in action. It was a promise made. When it comes to improving medicine access and affordability, court strongly believes that rare diseases represent the area with the greatest unmet need in Canada. The federal government was focused first on rolling out the promised funding for rare disease treatments before undertaking another major pharmacare plan. However, with respect to the bill itself, court has a number of comments. The predetermined categories, lists of medicines, and proposed single-payer approach, all of which risk limiting treatment options and potentially bringing everyone's level coverage down to the lowest common denominator. This is a concern. Additionally, Bill C-64 outlines specific timelines for its key components, yet the rare disease drug strategy lacks a detailed implementation plan and time frame. The rare disease drug strategy must also be afforded clear timelines, publicly accountable milestones, and opportunities for patient and clinical input. This is not in the current rollout. Lastly, the formation of expert committees, as stated under Bill C-64, must ensure genuine advisory roles. Court's experience with the current rare disease drug strategy implementation advisory group is that it has highlighted significant issues with transparency, with communication, and accountability. Effective implementation of national pharmacare requires these committees to provide meaningful input rather than serve as mere formalities. I'd like to close by noting that Canada has an opportunity to become a leader in providing access to cutting-edge therapies that significantly impact patients' lives. We must aim high, ensuring that our national pharmacare program and the rare disease drug strategy deliver the best possible outcomes for patients with rare and common diseases alike. Thank you very much for your attention. I'm open to any questions you may have.
Well, thank you very much, and we'll now begin with rounds of questions, starting with the Conservatives. Dr. Ellis for 6 minutes.
Thank you very much, Chair, and thank you to everyone for being here again today. This legislation, sadly, is being pushed quickly without adequate consultation, but that's a whole other story. Dr. Juan Rieger, if I could start with you, please. You talked. I tried to make a point here yesterday, and sadly, when the minister was here and two officials, they couldn't answer questions about the drug approval process. But you talked a lot, sorry, not a lot, but a fair bit about the approval process and how long it takes in Canada. Could you explain that perhaps for the members on behalf of all Canadians that we're falling behind and how long it takes to get drugs approved in Canada?
Certainly. First of all, just to say that because the approval process is so complicated, many companies do not want to come to Canada first. It takes too long. And quite frankly, it means then that even for the drugs to come in, it's oftentimes months and sometimes years after they're brought into the other OECD countries. So that's the beginning. We obviously have a multi-step process. We have Health Canada, the regulatory process, which I must say has actually done a great deal to shorten the timelines. We've got then to go to, we've got the Patent Medicines Price Review Board, which provides guidance in terms of the cost, the maximum price of the drugs. It goes to the health technology assessment groups, the now Canada's drug agency, CADTH, and INES, which again adds months and sometimes longer than that to the process. The big challenge comes when, for the public drug plans, the drugs then go, if they're recommended by the technology assessment groups, they go to the Pan-Canadian Drug Agency. And there they can actually take months and sometimes years. We've got drugs that have been sitting there for multiple years, even before they get picked up to be negotiated. They negotiate the price there. And there is no timeline, there's no transparency, there's no input into the process. So there they can languish. And then, even if they get a negotiated price, it is not necessary that every province actually lists these drugs, even though they signed on to say, yes, we will be part of it. And so again, we have the problem that these drugs now, sometimes not just months, but years later, are not even listed in the public drug plan. So, and in some cases, they never get into the public drug plans. There's no way of making them be there. So this is the challenge. And as we can say, for patients, of course, it is a terrible problem, especially for these patients that are waiting for life-saving therapies, rare diseases. We do not oftentimes have another therapy. But as I say, it's also a disincentive for companies to even bring the drugs to Canada. And we oftentimes have to really beg them to bring the drugs here because they know it is not only long, but it's a very, very complicated process.
Thank you very much, Dr. Wanriger. And I think then it's really quite fair to say that there doesn't appear to be any oversight on this process. And of course, you know, when we look at some of the statistics from 2012 to 2021, there were about 460 medications that have come to Canada, and only 44% have been here. And of course, that can certainly acutely affect those with rare diseases, as you've highlighted. So thank you for that. You talked a bit about you know, the government's announcements that they've made specifically around rare diseases and their failure to deliver. Do you have concerns that this is simply another photo op opportunity here and nothing's actually going to happen?
I hope not. I certainly hope not. I think there was sincerity around understanding the needs of Canadians with rare diseases. I do believe that there's the monies there that's been put into the budget, and we've been assured. We are extremely, extremely concerned, though, that it is not coming out. And again, as I said, we've seen it. The majority of that money is $1.4 billion out of $1.5 billion to be allocated through bilateral agreements. And this is, again, what we're hearing in pharmacare. And what we know is that well over a year later, none of these agreements have been put in place. We don't even know there's been discussions around them. So whether it's just bureaucracy, whether it's just the cumbersome of the process, whether it's really hard to get provinces to agree, I don't know. But this is not the way it needed to be. And we're hoping it's not a photo op. We're hoping that it doesn't become just a hollow promise. But that's why I said when we were concerned about pharmacare coming out, one, does it delay getting the rare disease drug strategy out? But two, is it going to fall to the same kinds of issues that our drug strategy has?
Thank you very much for that, Dr. Wanriger. Very insightful on behalf of Canadians. Ms. Berg, if I could turn to you, I think we have a little under a minute left. But you talked about supply chains in Canada, and you know, from the list of medications we've seen, it appears that some medications, let's just pick metformin, which is incredibly common, that there's a suggestion here that this may only be a single source supplier. And can you tell us a bit about how that may be a problem on behalf of Canadians with respect to drug shortages?
Sure. So as I mentioned, when we do, when a government awards a contract to a single supplier, others have no incentive to stay in the market. I can't speak specifically to metformin, but there are other examples. When you know, when one firm gets, let's say, 70% of the market or 80% of the market, the other competitors they're not going to make any money on this. And likely they're going to stock the product and it might go bad, it'll expire, and they'll lose money that way. They're businesses. They need to cover their costs. So globally, and a lot of our pharmaceutical manufacturers are global, will make the decision not to sell that product in Canada because they simply can't recoup dollars. And it's that simple. It's dollars and cents and economics.
Thank you very much.
Ms. Berg. Thank you, Dr. Ellis. Over to Dr. Hanley, please, for 6 minutes.
Thank you very much. Thank you to all the panelists for appearing today. I just wanted to maybe begin by pointing out on the testimony of Dr. Wong Rieger that you gave. I think one of the important pieces to highlight is how important this program is. This is Canada's first ever strategy for rare diseases, and I know Canadians, particularly the Canadians that you represent, were very happy to see this. And to me, I would interpret this as complementing pharmacare as part of the package, as it were, and it admittedly does require some time for implementation. We're all looking forward to that. I'm going to begin my questions with Ms. Silas. Ms. Silas, you and I have had many discussions over the last couple of years about pharmacare. Thank you for the socks. On my socks, it says comprehensive, accessible, universal, portable, and public. And I understand. I understand that that they're, well, we have to unwrap them. But the socks have been waiting for some time. I think they've been in storage. Can you tell me a little bit about that?
Well, we all remember the 2019 report from Eric Oskin, and Dr. Oskin and I were planning the pharmacare party, and then COVID hit. But I have to say, to join you in congratulations, Dr. Wong. I've been on many panels with Durham, and when I read the brief of C64, I was as excited to see rare disease there because 20 years ago we weren't talking about it. Now, I believe the bureaucratic rules and obstacles shouldn't stop us from doing the right thing. We're improving health and we're improving the life of Canadians with this bill. It's a door open and we need to move on it.
Thank you. I wonder if you can talk from your point of view. I mean, you've traveled around the country on this. You've talked to frontline nurses everywhere in the country. What is your perception of that there is a fear that this is going to have an adverse impact on private insurers, on employment plans, such as we enjoy as members? But maybe you can talk about what you think and what you've learned from other countries on what the effect will be of pharmacare on private insurance.
For nurses themselves, they're 90% unionized, so they're not worried about themselves. They're worried about their patients, and that's why they gave us a mandate to work on a national pharmacare program. But as a union negotiator, I remember the days negotiating with an insurance company where we had to beg to have smoking cessation program, but the plan couldn't afford it because of the usage. We represent 92% women. We could not add contraceptive. Now, we won that fight. I have a staff team here of Ottawa, a very small staff team, but because they're so small, our plan is very restrictive. So many rules, so many restrictions. I'm just glad that no one is really sick because they wouldn't be covered properly. And that is the game that we play with insurance. But as a negotiator, I also know that we will be at tables and asking for example, I expect pharmacare would provide 4 pills a day, but an insurance company will provide the richer pill of 1 pill a day. And that, when we talk to our members, they understand. But their dear commitment is to those children that can't have puffers because they're asthmatic, or to those children and parents that can't afford the better diabetic programs. That's where they want us to all work on.
Thank you. We know that there are concerns about the cost outlay to implement pharmacare. Will be an investment. It will cost money. We know that the reports, such as the Hoskins report, have done the analysis to show that overall this is going to be a cost savings to our healthcare system. Can you comment on the financial cost benefit of pharmacare, such as we are now embarking on?
I think you'll have great experts to talk about the dollars and cents later on. But our point of view, the money is already being spent. And either the money is being sent by Canadians who cannot afford it, so they either pay for their drugs or pay for their foods, and that is 1 in 5 families that can't afford their drugs. The money that Dr. Oskin was talking about, yes, it was 6 years ago already, is different. We have to give the support to the parliamentary budget officers to look at a universal program, not a patchwork, and they have to come up with the right formula. But as a taxpayer, I know the money's already being spent. It's just not being spent at the right place. And all the evidence from the economists we've worked over the last 30 years, they all tell us the best way, similar as our healthcare system, is to have a public system to provide the evidence in regards to which best drugs to give. And that's probably more to you, Dr. Hanley, because you're a doctor. But like when I met the minister yesterday, I said, it's really not up to you, minister, to decide what's on the formulary or which diabetic drug. It has to be a group of experts that deal with it. And that's what we're promoting.
Thank you, Ms. Silas. Dr. Hanley. Suite, M. Blanchet-Jonca, pour 6 minutes.
Merci beaucoup, Monsieur le Président. Je salue les témoins.
Thank you very much, Mr. Chair. I'd like to welcome our witnesses for this first panel of our study. My first question will be for Ms. Linda Silas. I'd like to first off congratulate you for your 20 years of work and as part of the Canadian Federal of Nurses Unions. You graduated from University of Moncton, by the way. So I have very affectionate feelings for this university that represents Acadians. So Ms. Silas, of course, you are aware of the situation in Quebec. We have our own pharmacare plan. It's not perfect, of course, but there's 30 years of experience there. So from your point of view, what can the federal government do more or better that the government of Quebec is not able to do at the moment? Thank you for the question, Mr. Blanchet-Jonca. Quebec is recognized as one of the leading programs across the world, but also as one of the most expensive for the state, for the government. So the unions in Quebec and the Coalition for Health is asking the federal government to intervene more, to be a part of it more. But of course, I'm not concerned about that aspect, but what I'm worried about and what's worrying for nurses and members of our organization is cases that fall through the cracks. So situations that are not covered by employers or those that are not covered by a provincial plan. That is where we need to be able to introduce this program to cover everyone. So I'd like to talk about the cost of drugs. You refer to Quebec as being expensive in that sense. But there's bulk purchasing, of course, which helps to bring the amounts, the costs down. And I know this is a position that you're defending at the Federation. I'm going to talk about health transfers, because the agreement is such that 50% of these costs are to be paid. That is the expectation, rather. We have arrived at 22% after years, and now there's a suggestion to bring that to 35% in Quebec. That represents $6 billion, but of that amount, we have only received $900 million. So if we ask for $6 billion and we get $900 million, then that means we will have less money to invest and to modernize these systems and these plans. I am on the same page with you on that one. I don't really understand the red tape issues that exist between the provincial governments, territorial governments, and the federal government. It doesn't really make sense that money that has been promised for rare diseases a year ago, $1.4 billion that has not been spent yet. That's an example that Dr. Wong has just given us, and that doesn't make sense. And it's also similar for the health transfers that were negotiated last year. It doesn't make sense that provinces and territories have not received this money. So that's a problem that the Minister of Health should look into with great detail. You know, Ms. Silas, there's the concrete example that the federal government reduced these transfer amounts to introduce a pharmacare only to end up withdrawing its investment. What would be the impact of that? Because provinces are trying to make ends meet in terms of providing for these programs, and we have accelerated privatization in some services, nursing services, for instance, that I know is a great concern for you. It's also a concern that I share. But how can we make sure that if you have a good idea, how do you then go about implement it in the best manner possible? That's a very difficult question. But since 2019, the federal government has promised to put in place a national pharmacare program with a list of essential drugs, and then we had the pandemic. But the negotiations between the NDP and the Liberals were all about paying great attention to two classes of medications, and then a guarantee that steps will be taken in the right direction. So thousands of Canadians would receive a guarantee when it comes to certain groups of medications, but I do have faith in the system. Okay, perfect. Ms. Silas? Yesterday, we had witnesses who talked to us about their concerns. In Quebec, there's a list of drugs that include about 8,000 items. It's not perfect, of course. Improvement is always possible, but the universal public system might end up having the effect of reducing the number of drugs. For instance, Ozempic would be a good example. It's a known drug. So how can we make sure that we will not end up losing indispensable drugs? Well, I tip my hat off to Quebec, and I think in BC as well, they have around 8,000 drugs, and it's one of the most comprehensive lists in Canada. But it's not up to politicians to decide what goes on the list. It's not a publicity campaign that will help us decide what drugs should figure on the list. It's not even up to physicians. It's up to expert committees to decide what goes on the list. Thank you, Ms. Silas.
Julian, please, for 6 minutes.
Thank you very much, Mr. Chair, and thank you to our witnesses. Ms. Silas, there is no doubt that Canada's nurses are the folk heroes of the Pharmacare Act, and you'll recall 3 years and 3 months ago, we were working together on the Canada Pharmacare Act. It was a bill that I'd sponsored on behalf of the NDP. Canada's nurses did an extraordinary job. 120,000 Canadians wrote to Liberal and Conservative MPs to say pass this legislation, and we were all profoundly disappointed, as were most Canadians who support pharmacare, that bill went down to defeat with both Liberal and Conservative MPs voting against it. Now, 3 years, 3 months later, you're testifying on behalf of the Pharmacare Act, which is extraordinary, and you've sent a message to all parliamentarians. Passing this bill will help patients with diabetes and women who face the impossible choice between buying groceries and filling their prescriptions. This is not just a healthcare issue. It is a matter of fairness, equity, and access. Investing in pharmacare will save lives, reduce overall health care costs, and enable people in Canada to lead healthier, more productive lives. We need you, speaking to all parliamentarians you are, we need you to act quickly and decisively. Your job is to protect and help build a public health care system that works for all people. Nurses across the country are doing their part. So put aside partisanship and let us make pharmacare a reality. That is an extraordinarily important message that you're sending to all parliamentarians and to members of this committee. I'd like you to tell us what Canada's nurses have seen on the front lines with the lack of pharmacare, with the lack of medication being available, with people struggling to pay for their medication. What are some of the stories and what are the things that Canada's nurses have seen with the current system that lobbyists say is fine, but that Canadians want to see fundamentally changed?
Today, what we hear on the news is the long lineups in the ERs, the long waits for surgeries, and of course the shortage of nurses and other healthcare But the reality are the simple things. The reality are those families that cannot afford their medication and stay in the hospital longer. And doctors and nurses will, for the health of the patients, keep those patients in the hospital longer so they can get their full treatment. And that is where nurses get frustrated. We have patients in hallways because they don't have any other choice. And we have to do better. We're the only country that has a public system. And I guarantee you, I'd stand on any tribune to defend our public system, even as difficult as it is today due to the attacks the pandemic gave on us. But we need to give that extra to our doctors and nurse practitioners, because right now they're stuck. If they don't have a sample to give that to that family who doesn't have an insurance plan, the patient has no other choice than to go in the ER and get their treatment. And that's not fair.
And what does that mean in terms of cost to our healthcare system when people are being kept in an acute care bed because nurses understand that if they're released, they won't be able to pay for their medication?
It's the cost of hospital days, but it's worse than that. It's the human cost. Go take a walk in any of our hospitals today. The hallway nursing is scary. I feel for those families, especially our seniors, what they're going through in hallways, because it's a ripple effect. They're in a hallway because there's a bed, because somebody can't pay their medication, or they didn't adhere to their prescription. Family docs or specialists and nurse practitioners know what they're doing. And if they prescribe a medication or a series of medication, we should have a system that continues to protect them and continues to give them access to their medication.
So when people don't have the ability to pay for their medication, I know Canada's nurses, I know you have done remarkable work on this. What does that mean in terms of the cost of human lives? Are Canadians dying because they can't afford to pay for their medication? And what does that mean in terms of numbers? Are we seeing Canadians losing their lives because of the lack of universal pharmacare in this country?
But MP Julian, you're really hitting a hard line with the nurse in me. We did a report a few years ago on the number of patients dying, and just with two categories, which was diabetic and heart disease, we were talking in the thousands that were dying every day. Not every day, sorry, every year because of the lack of medication. I didn't even understand that Stat Canada was collecting the data of patients not being able to take their prescription drugs and the impact it would have in long term and dying. But that's the extreme. What we're talking today is giving them a chance with these two types of drugs to have a healthy life and to have more control and not to enter our hospitals or our emergencies to get their prescription drugs.
Ms. Saez, do you recall the numbers per year?
I don't recall them.
Yeah,
And I
okay.
was looking at my notes. They're not there because that's a report probably 2013. But I will provide it to the committee.
That would be
Yeah.
very, very helpful. So people are losing their lives because they're not being able to pay for their medication. This is extraordinary in a country like Canada that we would permit that. So when there are company lobbyists that come forward into this committee and they say everything's fine the way it is, would you agree with that assertion that everything's fine the way it is when people are dying?
Okay.
After that report, the Heart and Stroke Foundation partnered with us to lobby for a national pharmacare program because realizing that heart disease are big and the same thing with diabetes. So it is, it's hard to understand. As I said in my statement, we believe in the national pharmacare program because we believe in the care we provide to our patients and we want to do the best job possible.
Thank you.
And it's on pharmacare.
Thank you,
Others
Ms.
have other motives.
Thank you. Next, Dr. Kitchen, please, for 5 minutes.
And thank you, everybody, for being here. It's greatly appreciated, especially on such short notice and as quickly to get through as we look at this. I think most Canadians that have been following this are expecting us to be discussing the legislation. And they want us to be here to discuss the legislation, to sit around the table and come up with changes that we think need to be done to make it even a better piece of legislation. And that's a challenge as we move forward, because they assume that when we come up with points that are pertinent points, they actually will get passed. And the unfortunate part is that they probably may not get passed. And that's unfortunate, because Canadians that are watching us are expecting and hearing what's been going on, are expecting this legislation to be improved. And it's scary to believe that this coalition that's trying to push this through may not do that. A number of people have brought up, and we'll talk about, I would like to just address one, or to start off with, is, and many of you in particular, Ms. Berg and Dr. Wong Rieger, you mentioned the issue about basically committees and experts to deal, and how do we address that? And when you look at the legislation where it does that, it doesn't at all talk about how big this committee of experts will be. What are those qualifications of who those members will be? Will they be from each province, or will they be from a select group that's determined by the minister and by the minister only? They're not to mention the cost, et cetera, along those lines. So to you, Ms. Berg, I guess my first question to you would be, when we look at that from a pharmacy point of view, and in particular, and last night with some of our witnesses from pharmacy, they had brought up the issue of maybe having a pharmacist as one of those experts. I'm wondering if you would be able to comment on that.
Certainly, I think that the Pharmacists Association yesterday made great assertion to have a pharmacist on that expert committee, and we fully support that. Captain's distribution members get medication to patients, but they arm our professionals with the tools of the trade. So they're extremely important, and they should be on that expert committee. We would like to participate on that expert committee. We're very concerned about the unintended consequences on the supply chain that actually delivers medicines to Canadians. We would like to work with government and make sure that we're helping inform you to be sure that there's enough money to support that. When I said that there are, we're at a precipice where there's so much expense having been driven out of the distribution system, we're really at a place where the only way to take the impact of any further price reductions is to cut services, and that's going to hurt. And nobody wants to do that. So we'd really love to be part of that as well.
Thank you, Ms. Berg. And Dr. Wong Rieger, you also sort of indicated that in the aspect of on that advisory role, and I'm just wondering if you would like to hear your comments on where you see that role being.
So, as I said, we have an implementation advisory group right now with the Rare Disease Drug Strategy, and I've been on other advisory groups with the government as well. The challenge, I think, is that in many cases, we're not really advisors. There's already a decision being made. The decisions are oftentimes being made behind closed doors. We've been begging the government to tell us what's going on in terms of these bilateral agreements. What are the talks that are taking place? What are the drugs that are being considered? Can we provide some input in terms of what those drugs are? We're giving no opportunity to do that. So I think the challenge is, if we're going to have these committees, they must be transparent. There must be accountability. We've been asking for the opportunity to let the public know in terms of what the progress and plans are. And again, we've not been given that opportunity. So I think part of the challenge is in the details and making sure. I think the other thing I'd like to say is that, as we've heard already, it takes so long to get drugs through the public drug plans. And I'm not saying that, whether or not things can be improved through the public drug plans, but we know that if you have private insurance today, if a drug is approved, a rare disease drug, you almost always get it as soon as possible. If you're on a public plan, I've got 2 or 3 years with patients saying, where's my drug? And it's not yet there. Even though it's going through so-called expert committees, there's not the transparency, there's not the ability to have the right people having to push for those decisions.
Thank you, Dr. Wong Rieger. Thank you, Dr. Kitchen. Next, Dr. Pawlowski, please, for 5 minutes.
So we've heard from the Canadian Association for Pharmacy Distribution and Management. I hope I have that right. The Canadian Organization for Rare Disease, and I think both of you kind of sounded a bit of a note of caution about C64 as being potentially a threat to accessibility, accessibility drugs for rare disease. Perhaps I'm not so surprised about that coming from you, Ms. Berg. I am a little bit from Dr. Wong Reiger. Certainly this bill does not create a single payer system. We don't know as yet what national pharmacare is going to look like. Potentially, though, it would be a single payer system. I would have thought, and particularly Dr. Wong Reiger, that there would certainly be benefits from a single payer system. I would have thought it would be more efficient. There's certainly cost savings to be had. There's certainly economies of scale to have one system, because right now you have all these different providers, and each of these providers, each of it has its own management, and each of these management and CEOs, they take a little bit of that money. Money which in an employer-employee's drug plan money which would otherwise probably be going to the employee instead goes to the profits of the company that's providing the plans, right? So if you were to have one big plan administered by the government, you have economies of scale, and there would be no profits, money being siphoned off for profits. There wouldn't be these many bureaucracies dealing with these different plans. There'd be savings there. But plus, in addition, if you're buying like 10 million pills at one time, you're going to get a better deal from a manufacturer than if you're buying 100,000. So if there was more money overall in Canada to be able to buy drugs for everyone, wouldn't we have more money then to be able to afford money for rare drugs for rare diseases, which are often expensive? And also, Ms. Berg, you were talking about shortages. Wouldn't we have money for providing a emergency stockpile of medications so we didn't have shortages? So I'll start maybe with you, Dr. Wong Reiger.
Yeah, thank you very much. I love your ideal approach here. And this is absolutely what we would love to see, is the ability to move these drugs through in a timely fashion, to be able to make them available to everybody at the same time, and certainly, as you say, to have equitable access right across the provinces. What we do know, and this is where the details come in, is that under the way the system works now in the public plan is that they get bogged down. They get bogged down in many steps of bureaucracy. And quite frankly, we know that the drug plans themselves do not allocate enough money. In many cases, in many countries, and let me get outside the U.S., there is the sense that drugs, and the best drugs, are actually an investment. And I heard what Ms. Silas was saying. The trouble is that if you're not providing people with their optimal therapy, if you're not making sure that people get the medication that's going to actually keep them alive or keep them out of hospital, and you're providing everybody with the same therapy, which sometimes is what happens, or you will not invest in the best therapies, then in fact it doesn't work. So that's our concern, is that in many cases, it comes down to the lowest common denominator.
So you're concerned that any government-provided plan would get the basic medication. If you needed something a little better than the basic medication or something other, a variation on it, you wouldn't be able to get it in the public, which wouldn't necessarily be the case. But is that your concern?
But it is the case right now. And that's the problem, is that the public plans bulk. They put very, 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 kind of high, restrictions in terms of the access to it. So this is the problem. And, when you look at even the recommendations that are coming out, what the recommended price that they'd be willing to pay are so low that, when you ask a company to take a 90% reduction in terms of the proposed price, companies are not going to do that. In many cases, they won't even come to Canada. So I'm not saying that, this cannot be done. I'm just saying that when you have a bulk plan that says, fine, we will negotiate, but we expect you to give me a 90% reduction, which if you read the recommendations that are coming in and you see what's going into the pan-Canadian drug lines, that is exactly what's happening. So this is what the problem. Yeah, in reality, this is the problem. Ideally, I would love your plan.
Yeah, no, then can I suggest then maybe your argument isn't so much with the public provider, but rather than the fact that the providers that are kind of limited in their willingness to go outside the box and want to kind of stick to a formula, in which case perhaps you don't have any problem with public per se, but just the way public systems are administrated?
Briefly,
As a
please.
patient, I don't care who's paying for it. What we need to do is make sure it's paid for and that it's affordable to the patients, quite frankly. So yes, we very much agree with the idea of having the ability to have that single price that would be available, but it needs to be done in a way that's realistic. So the problem we have is if we roll out the public plans that we've got now and we make that the only plan, it means that people are going to be waiting 6 years to get access to the best medicines.
Thank you, Dr. Wong-Rieger. Monsieur Blanchette-Jonca pour 2 minutes et demie.
Mr. Blanchette-Jonca for 2.5 minutes. I'll continue with Ms. Silas. I fully agree with what you just said. It's not up to politicians to decide what goes on the list of medication that will be offered within this plan. Now we're talking about 8,000 drugs on the Quebec list. But who will decide on what goes on the list? Is it the Drug Agency of Quebec or is it the National Institute on Health and Social Services that is already in charge of 8,000 drugs? Who would be the best people to decide that? Someone who has 30 years of experience or someone else who knows about the field? But how do we go about improving the medication list in Quebec? Well, I think you answered your own question. When you look at the bill, it's really up to the federal minister to consult with the provinces and territories and experts to decide on what goes on the list. So it's about working with Quebec and Quebec's experts, but also Canada is a small country with a population of 39 million. We have a lot more advanced experts elsewhere in the world with public programs, with lists that function really well. We are at 40 million, Ms. Silas. All New Brunswickers then. We will have to look at the census data, but Canada has some of the highest demographic growth rates in the world. So my question was more geared to understand what the government of Canada can do that INES is not doing, the Excellence Center in Healthcare and Social Services in Quebec. Well, it goes beyond my field of expertise, but when I was talking with Duran, we realized that there is a problem with the bureaucracy through which drugs are approved and distributed. That's a big problem. We have to look into it. I don't think that it will change the bill, but it's a red tape problem that the government has to look into. Thank you, Mr. Blanchette-Jonca.
Ms. Zarillo for 2.5 minutes. Welcome to the committee. You have the floor.
Thank you so much, and it's a pleasure to be here. Thank you. And my questions are for Ms. Silas. Nice to see you today. Wanted to talk about two things. One was gender equity, which you brought up earlier, and the second one is just around poverty. So as the critic for disability inclusion, and we know that the Canada Disability Benefit is not going to fulfill or fill that gap to make people, to help people to lift to the poverty line at least. So I wanted to understand from your experience and from the experience of your members how poverty affects health and how this pharmacare bill could help to alleviate some of those outcomes that are tied to poverty. And then second of all, if you just could follow up on the gender equality note that you introduced, like how is the access to free contraceptive going to generate equality in our society?
Poverty has a long list of issues to be dealt with. I don't think anybody is suggesting one solution. And this proposed act is not one solution to eliminate poverty, but it's one solution to give access, equal access to the needed prescription drugs, regardless if you're high income or low income or living in poverty. And that's where nurses are coming. It should not depend on your level of income or if you're insured, if you're going to get your prescription drugs. And that's from day one since we've been supporting a national pharmacare program. In regards to gender, if I look at our nurse practitioners and our regular registered nurses, the whole contraceptive movement is changing day to day. It is not the same way as when I was in my mid-20s. It was just one pill. Today, it's a concept where the health domain has expanded and is helping women of all ages. And this is one way to help more than 50% of the population. And it's important to go forward with the bill to make sure that we do that. Because again, it's one piece of the puzzle to help gender equality. It's one piece of the puzzle to help in our poverty situation.
Thank you, Ms. Silas. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. And it was interesting when our colleague from the NDP, Mr. Julian, was here previously. He was perhaps saying some disparaging comments about lobbyists who were here yesterday. But Ms. Silas, you too are a registered lobbyist. Is that not true?
Proudly. You want a pair of socks?
No, thanks. I would be afraid that might be a conflict of interest, lobbyists giving gifts to parliamentarians.
Oh, they're below $50.
Currying favor with their votes, perhaps, but that's a whole other story. One of the things you talked about, Ms. Silas, previously was related to patients being in hallways in healthcare, and it would appear that you conflated that to actually patients not having medications, which could be one of the issues, but is it really not more of an issue that almost 10 million Canadians don't have access to primary care?
Yes, that is similar to the question on poverty. The access to health care is about primary health care. It's about access to medication, and it's about access to our acute care and long-term care. So if we're not able to fill all of those, and I'm forgetting, sorry, mental health. So if we're not able to fill all those silos, right now they're working into silos, our society will not be as healthy as possible. So availability to prescription drugs.
Thanks very much for that. You know, it's interesting. I would suggest that, over my career as a family doctor, I've known many nurses. They're quite happy to have their private drug plan, which covers many things, which sadly, due to the difficulties of their jobs, it requires them to have access to physiotherapy, often chiropractors, mental health practitioners. You know, what would you say to the nurses out there who might be afraid that they're going to lose their plan? Now, you would suggest that that's never going to happen. We've had other witnesses here who would say, yeah, that's a really good likelihood that that's going to happen with a national universal single-payer system. So if that happens, what do you have to say to nurses out there when they lose their plan and all they have is, a couple of birth control pills, no physiotherapy, no chiropractic, no support hose, no mental health access? What do you have to say to your nurses about that?
Well, first of all, this bill doesn't deal with physiotherapists and support hose. It deals with two categories of prescription drugs. And what it will do is it'll bring equity across the country. For our nurses, I never got the mandate to examine their own plans. That's bargain it. I know it's at the bargaining table in every province and territories, and they do a great job. They're not worried about themselves. They're worried about the patients they take care of. They're worrying about that patient that falls through the cracks in Quebec, like I was telling Mr. Jonca, or they're worrying about the patient that doesn't have any plan.
Ms. Silas, I'm just going to interrupt you there because that wasn't my question. My question to you was, if this comes to fruition and nurses out there do lose their plans, which I know your contention is that's never going to happen. We've heard from other witnesses who says that's a definite possibility, that, with previous court cases, et cetera. What do you have to say to your nurses out there when we know, as our colleague from the Bloc mentioned, that public plans cover significantly less medications, and as you mentioned, perhaps no physiotherapy, chiropractic, and other important things on behalf of nurses? What do you have to say to your nurses if they lose their coverage?
I'll negotiate them a better plan.
But Ms. Silas, that's absolutely not true because there's only going to be one plan available to them. So, I mean,
Yeah.
this is not something that I find humorous because I know many nurses. You represent them. What will you tell them when they don't have a choice? How are you going to negotiate another choice when there is no choice?
Dr. Ellis, I have 20 years of mandate nationally to negotiate a national pharmacare program from nurses from every sector of this country. And they are not worried about not having a plan. They'll always have a plan. Some are richer. If you look in Alberta, the plan is very rich in Alberta on every facet compared to my own province in New Brunswick. But that is negotiated at the provincial level and will continue to be negotiated at the provincial and territorial level. What we're looking is to alleviate some of the costs to those plans to be able to enhance. So maybe better mental health services, maybe better physiotherapists, better support hosts.
I don't share
Ms.
your
Silas.
optimism, but thank you very much for your opinion.
Thank you, Dr. Ellis. Next, Mr. Joe Harry, please, for 5 minutes.
Thank you, and I'll continue on that topic with Madam Salas. So, am I right to understand that as a result of the introduction, a preliminary introduction of these two type of products, diabetes products as well as contraceptive, it will allow more room in the insurance, broader insurance programs and benefits, so it can help actually broaden the scope of other services as you were trying. Did I understand you correctly? Can you expand on that?
That would be the best scenario. But in 2024, until the act and until the program has some experience where it will have an impact on our employer-funded health programs for sure, where that money will be reinvested will depend on the committees in the provinces and in all employment. I'm talking about the public sector and healthcare. But it'll be the same thing in an auto company in somewhere in Ontario. They will negotiate the excess of money when that happens.
So when you say it will have some impact by 2024, can you explain what that impact is?
I can't explain it honestly, not with specific numbers. What I can explain, let's say the diabetic drugs are 10% of your health care costs and it's spread around. Well, that 10% will be reinvested in something else because it will be covered by the province and the federal government's plan. That's the best example. Until we have experience, nobody will be able to tell you the exact amount. Now, saying that, I'm sure there's an economist that might testify and be able to do that.
I understand you're a nurse practitioner as well. So based on your experience or based on the experience of the nurses that you represent, how many times been in the hospital in emergency that Canadians have shown up with symptoms that relates to diabetes? That it's because of the lack of access or because of the rationing, they ended up in emergency. And how much an emergency visit costs?
I haven't practiced in over 25 years, so I'm really not the person to ask. And I'm a registered nurse, not a nurse practitioner. What we have done over the years is brought practicing nurses and physicians have come also to talk to parliamentarian on the lack of access to drugs. Most of the time we leave the dollars and cents to the economists to explain the cost impact. What we're saying is the human impact of having people having to go to see a physician or a nurse practitioner and beg for a sample drugs, or the rare disease that Duran was talking about. We should not be in a situation to beg to get care in this country, and access to what your doctor or nurse practitioner prescribe should be included.
Okay, thank you. I'm going to go to Ms. Berg. Ms. Berg, you talked about the supply chain, and you talked about the distribution and the impact of the potential impact of this bill, especially the buying power, in the distributors actually stocking and stocking less or eliminating those products from their offering, and also other manufacturer who are not going to be as part of successful in their bid. They're going to stop completely the manufacturing and or distribution in Canada. How realistic is that? How realistic is that? That a global pharmaceutical company is going to basically says, oh, okay, I'm not going to manufacture penicillin anymore, and I'm going to go. I'm not going to sell it directly to the government. So I'm trying to, I only got about 10 seconds, but can you quickly respond to that?
Happy to. So it's not that they will stop manufacturing, they'll stop sending it to Canada, and that's happened. It has, and Durhan has spoken to that also. We hear that that's kind of skeptical assertion, that medicines will always be distributed everywhere, just like groceries. But unlike groceries, drug prices are controlled. They're not uncontrolled. They have thin margins and low volumes. They're not high volume things that you can throw on any old truck. Their handling is extremely complex. It's highly regulated, and it requires dedicated transport in temperature-controlled vehicles. They do not store easily, and they don't move cheaply. And when we think about, well, it'll just go along with the toilet paper, that's not true. It can't happen. We have all kinds of regulations on that to prevent that from happening, to maintain the product integrity and patient safety. So it will happen. It won't happen overnight. It really won't. We'll watch it erode slowly, slowly, slowly.
Thank you,
and the access will worsen.
Thank you. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you, everyone, for, again. It's interesting to hear some of the responses we've had, and to you, Ms. Silas, I'm just wondering if you understand what the question was given by my colleague. My wife is a nurse, 40 years. She did her first year as a neonatal intensive care nurse in Edmonton, University Hospital in Edmonton. She then went to Sick Kids in Toronto and was an ICU nurse at Sick Kids in Toronto. She went from there to Royal University Hospital in Saskatoon. She went from there to working in Crosby, North Dakota, and then back to St. Joseph Hospital in Estevan, where we live today. And then was basically a critical care long-term nurse. And her conversations, as I watch and as I've seen, she is the best patient advocate in this world. And I would put her above anybody in coming up with that aspect of what she cares about her patients. But some of the things that you have said today shock me, because she's never said any of those things. And I find that kind of interesting in how that is, if that's the way the union sees the nurses versus the way the nurses on the ground see things. You did, though, mention one thing that I thought was very important, and that is the aspect that it's not up to politicians to be making these drug plans. And I agree with you on that. It isn't up to politicians to be making those decisions. It is up to experts to be doing that. And when the government comes out with a plan that hasn't talked to the experts, and in this case, we're talking about diabetes. And when the question would be, have they even discussed things with the Diabetic Association? And when we look at what the Diabetes Association has put out, and when they look at those plans, and this public plan compared to the FINHB plan, compared to their clinical standards, totally different aspects of how we see that. And the public plan is significantly less than the private plans that are out there. And I'm sure you're well aware of when Ontario came up with the OHIP Plus plan, and when they came out with that plan, which implemented a drug plan for people under the age of 25, and I'm not from Ontario, I'm from Saskatchewan, but the reality is they brought that out. There was a huge impact on young Canadians and getting their drug medication because they weren't able to access that. And that's what this piece of legislation is doing. It's putting forward a public plan that, as my colleague has indicated, that we heard yesterday, from many other places that are saying that the private plans will be cut. So for you to then say you're going to negotiate, that's not something that's negotiable. It's in this piece of legislation. So the question is, what do we need to change this legislation such that you would be able to negotiate in your steps as you move forward?
MP Kitchen, yes, any bill could be improved, but it has to start somewhere. And this is a start based on 30 years of evidence. And I do commend your wife for her role, and I'm sure she's a great patient advocate. I'm probably the best nurse advocate there is in the country. I've been elected 11 times to do that for the last 22
I
years.
apologize for interrupting you. My question to you is, what can we do? Because that's what we're here for, is to come up with plans to improve this. The role of this committee that we're doing here right now is to make, and how do we improve that? And what can we do today that would make those improvements and putting forward steps? And you're not offering any steps that would say to improve that part. You're saying you're just fine with this. But what I'm saying to you, what is fine with this puts people's lives at risk. To step forward for the 10% of Canadians that don't have a plan, regardless of whether it's a good plan or not, the bottom line is to provide the funding to help those people. This is going to not help them because it's going to provide only basic medications in the diabetes area, and it's not going to help others who have plans because this will take that away from them. So what can we do that you see here that we can change that?
Ms. Silas,
Honestly, stop stalling.
That's all the time for Dr. Kitchen, but take 20 seconds and do your best.
It stops stalling on providing Canadian access to medication. This is opening the door for equality into our healthcare system, and that I support this bill and will work on improving it in the years to come.
Thank you, Ms. Silas. The last person to pose questions to this panel is Mr. Nakvi for 5 minutes.
Thank you very much, Mr. Chair. And I'm going to start by reminding members of the committee that I had the great honor of serving at the provincial level in Ontario for 11 years. And I was part of the government that actually brought the OHIP Plus. And I was quite involved in the creation and development of that program. And I can tell you, forget from the government side, just from the perspective of a member of provincial parliament and talking to countless constituents of mine, young people, parents of young people who were able to benefit from OHIP Plus because all of a sudden they were able to get access to life-saving medications without any cost through just using their OHIP card. And it was a game changer in terms of providing the kind of support needed for people, especially for young people. And anybody who's a parent in this room or listening knows that there's nothing more important for a parent than making sure that the well-being of their children. And I met so many constituents of mine. So with all due respect to Mr. Kitchen, I can share with you my personal experience being a member of provincial parliament at that time in Ontario in terms of the impact it made and lack of it once Doug Ford's government took away that option, that choice, the suffering a lot of people are facing. So I'll go to Ms. Salas. Good to see you again. Thank you for your hard work and advocacy. Choice is coming up here often, that somehow this legislation is going to undermine choice, that somehow is going to take away the choice. I see it the opposite. I see it's actually creating choice, creating more options for people who don't have pharmacare, who are uninsured or underinsured. Can you, from your perspective and all the work and research that your organization have done, tell us what your thoughts are on choice and what this bill does in terms of choice available to Canadians when it comes to access to life-saving medication, and in this case, starting with diabetes and contraceptives?
First of all, I totally agree with you on OPIP Plus. We all celebrated when it was introduced. The only downfall, we were hoping the federal government would be doing that, similar as they did with dental plan. When you use the word choice, I see it again as an equal playing field for the essential medication that are prescribed across this country. The choice will be for those who can afford more. But the equal playing field for diabetics across this country, for women across this country, will be putting them on equal footing with everyone else. The choice will be the extras.
Thank you. And you've looked at this bill fairly closely in detail. Did you find anywhere in this bill mention of private insurance, or how private insurance will disappear, or people will not have the option to access or rely on their private insurance?
No, a lot, you look at the principle under 4, it's again talking about working with Indigenous people, with the province, the territories, the stakeholders on how to implement the funding aspect. Again, as we mentioned earlier, the rare disease is specially identified there, and it continues with diabetes treatments and contraceptive. It's important to look on the simplicity of this bill that the experts will be able to work with.
And nor anywhere in this bill there's any reference to removing drugs or reducing the drugs on what's covered by private insurance.
No, there's not one union in this country that would agree on eliminating the private programs that exist everywhere.
Can I ask the same questions of Ms. Berg and Dr. Wong Rieger in terms of private insurance? In your analysis of this bill, do you see any reference to private insurance, or that private insurance will not be available for those who want to access private insurance? We'll start with Ms. Berg.
Thank you. We're actually not familiar with the private and the public plans. It's business to business, the supply chain. So I would defer to Derhan. I know she's done tons of work in that.
Great, thank you.
Yeah, so thank you very much. I think for us, the concern is to make sure that, as you know, there are essential medicines, but in many cases, there are much more personalized medicines. There are much higher level medicines that are especially for those people who have that need. So I would agree very much with Ms. Silas to say that if you need an essential medicine, you need a basic medicine, as you say with OHIP, plus, that would be available. But quite frankly, we would love to have the bill to make it so that everybody gets the medicine that they need, and that nobody is actually reduced to a common medicine if, in fact, what they need is much more specialized. I mean, today we have private and public insurance for rare disease drugs. And I have to say, the sad news is that we get over and over again physicians, patients who tell us, the first question they'll be asked is, do you have private insurance? And if they don't have private insurance, they won't even get prescribed what would be the appropriate medicine, because it's not going to be covered by the public plan. So if there's a plan that provides, as you say, the optimal choice for each and every patient, and they can get what is absolutely the best for them, in many cases, people end up in hospital because they don't have the right drug. So yes, we would love to have a plan that would allow everybody to get what they need, regardless.
Thank you, Dr. Wong Rieger. And thanks to all of our panelists for being with us here today. Very much appreciate your testimony and the professional manner in which you've delivered it. Colleagues, we're going to suspend now until 1:45, and would like you to come back right at 1:45 because we're actually going to have 5 witnesses on the next panel. So thanks again to all of you for being with us. The meeting is suspended. I call the meeting back to order, and I'd like to welcome our second panel of witnesses for today. We have a couple of witnesses participating remotely, so I will just inform the committee that in accordance with our routine motion, all remote participants have completed the required connection tests in advance of the meeting. And for our remote participants, you will see on the bottom of your screen, you have the choice of floor, English, or French to be able to access the simultaneous translation should you require it. So without further ado, we're going to, the witnesses we have with us today, we have JDRF Canada, Jessica Diniz, President and CEO. Ms. Diniz, thank you for your patience as we work through the technical issues. We're going to start with you. We have as well représentant l'Association québécoise des
representing the Association québécoise des pharmaciens propriétaires
in Pharmaceutical Affairs, representing the Canadian Association of Retired Persons, Bill Van Gorder, Chief Policy Officer, appearing by video conference. On behalf of Diabetes Canada, Glenn Thibault, Executive Director, Government Affairs, Advocacy and Policy. Welcome back, Mr. Thibault. It's good to see you again. Russell Williams, Senior Vice President, Mission, and representing Smart Health Benefits Coalition, Caroline Egan, Principal Representative. So we're going to begin with opening statements in the order listed on the notice of meeting. So we're going to start with JDRF Canada. Ms. Diniz, welcome to the committee. You have the floor.
Thank you, Mr. Chair. I'm honored to be here. Good afternoon, members of the committee. My name is Jessica Diniz, and I'm the President and CEO of JDRF Canada. JDRF is the world's largest charity focused on accelerating research to cure, prevent, and treat type 1 diabetes and its complications, as well as helping to make life better every day for the people who live it. We also advocate on behalf of the 300,000 Canadians living with type 1 diabetes, representing their voice on critical issues such as national pharmacare. JDRF supports the goal of making access to medications and devices for treating and managing type 1 diabetes equitable, affordable for all Canadians. Patient choice needs to be a priority. Type 1 diabetes is a lifelong autoimmune disease in which a person's immune system destroys insulin-producing cells in the pancreas, making them dependent on daily injections of insulin to survive. I just want to underscore that. They require insulin to stay alive. So just want to make sure that is very clear. Managing diabetes represents a significant financial burden for Canadians impacted by the disease, and many treatments and devices remain out of reach for some Canadians. We thank the government for bringing diabetes and its high cost to manage the disease into focus through coverage under Bill C-64. While we align with the intention of Bill C-64 to provide fulsome, barrier-free access to treatments and devices for those living with diabetes, we'd like to raise a couple of recommendations to ensure the Bill C-64 meets the needs of all Canadians living with type 1 diabetes. First, National Pharmacare should not preclude anyone from using existing private and public insurance coverage to access insulins, whether they are listed on the national formulary or not. Bill C-64 should include a provision that clearly articulates this principle. Number two, based on consultations with healthcare providers and those living with type 1 diabetes, we'd like to see the list of insulins on the formulary be expanded to include more advanced insulins that help better treat the disease. It's a very limited list, including insulins that are rarely used and prescribed. It's important that physicians have therapeutic options to address the wide variation in individual patient responses to and tolerance of any particular drug, and that patients can access these as one insulin may work well for one person and not for another. I think this is a very important point. By expanding the choice of medicines, you increase the number of treatment options available to help eliminate side effects, reduce complications, and improve health outcomes. We also want to bring two areas of caution on how this program is implemented that we'd like to raise. Number one, changes in insurance coverage. The bill also creates a risk whereby the existence of the national formulary may motivate private insurers not to cover brand name insulins because some of the generic equivalents would now be available through the National Pharmacare program. If this happens, the consequence could be the automatic substitution of a different insulin, which can impact health outcomes. Also, another concern, number two, stakeholder engagement and consultation. This will be critical to ensuring implementation of a national pharmacare program best meets the needs of Canadians living with type 1 diabetes. JDRF is supportive of legislation that improves access to medications and devices for Canadians living with type 1 diabetes. We ask the government to provide clarity on this legislation to ensure it lives up to its intentions of equity and affordable access to medications and devices, and considers the input of various stakeholder groups that must have a voice in how national pharmacare is rolled out. It's critical to get the implementation of this legislation right to ensure it delivers on its promise, not only for those living with type 1 diabetes, but for all Canadians who will benefit from this program in the future. Thank you very much.
Thank you, Ms. Denise.
And now, representing the Association québécoise des pharmaciens propriétaires, we have Benoit Morin, President. Welcome to the committee. Please go ahead. Thank you very much, Mr. Chair. Parliamentarians, thank you very much for having invited me to appear here as the President of the Association québécoise des pharmaciens propriétaires. Here with me is Geneviève Pelletier, Senior Director, External and Pharmaceutical Affairs. I represent 2,050 pharmacy owners in about 1,900 community pharmacies throughout Quebec. Now, in Quebec, there is something very specific in the situation. You need to be a pharmacist in order to own a pharmacy, which means that professional independence and ethics take priority over business decisions. Patient well-being is at the very heart of our decisions and priorities. It is a unique system. In opening, I would like to say that our association is in agreement with the Canadian government's desire to improve accessibility and affordability of prescription medication for all Canadians with exhaustive coverage, but we wish to make the point that the current system in Quebec already meets the objectives of the Minister of Health. Quebec community pharmacies very clearly offer a high level of accessibility and first-line care. Pharmacy teams offer many services which go well beyond distributing and monitoring medication. And in order to offer these services, community pharmacies' financial health and funding are very important, and we are very concerned about Bill C-64 in its current form. Having a single-payer system in Quebec would imperil the current community pharmacies model and would harm patients. Currently, the funding system for these pharmacies depends on professional honoraria having to do with medication distribution and monitoring. And a decrease in these honoraria could decrease pharmacies' capacity for developing added value services for patients. We've had a mixed public-private system for more than 25 years under the Régime Général d'Assurance Médicaments, or RGAM. According to the proposed single-payer public system proposed here, pharmacists' honoraria for writing or renewing scripts for diabetes or oral contraceptives would be at a single amount negotiated for the covered medication, and the impact would be significant for pharmacists because these medications are currently being used by patients, mainly by patients covered under the private component of the RGAM, so nearly 7 million services in 2023. And that's the flexibility that enables Quebec pharmacies to develop, to be in all of the regions of the province, and to offer many services to patients. This blended system enables pharmacy owners to adapt to the specific needs of the local clientele, and they can react swiftly to market competitiveness. If the situation were less flexible, the pharmacy network's financial health would be undermined, and there would be even more significant impacts in remote regions. So it's essential that we maintain this joint system in order to ensure that our pharmacies remain sustainable and effective. That's what makes access to medication constantly guaranteed and also applies to the clinical role of pharmacists as a first line of care and in looking after chronic disease. For example, over the last 12 months, more than 7 million clinical activities and first-line care activities have been performed in Quebec pharmacies. So undermining that first line of care, which is essential for the health system, would harm patients. And I will just say here that the Quebec model already meets the objectives that are set out in the national plan: accessibility, affordability, and optimal use of pharmaceutical products. There is also universal coverage for all residents. In some situations, especially for low-income individuals under the RAMQ system in Quebec, the insured person's contribution is actually zero under the current plan. This joint system in Quebec not only enables the system to meet the goals of the bill, but is actually an improvement over the public regime. So in conclusion, having a single-payer system in Quebec would be counterproductive. And in fact, it would actually lead to a decrease in the ability to meet the objectives of improving accessibility. And it would undermine our community pharmacy model in Quebec, which is grounded in communities, and in fact is the envy of other Canadian provinces. Thank you very much, Mr. Chair.
All right. Next, we're going to go to the Canadian Association of Retired Persons. Mr. Van Gorder online. Welcome to the committee. You have the floor.
Thank you very much, and thank you to the committee for allowing me to appear on behalf of the Canadian Association of Retired Persons and our 225,000 paid members across the country. We applaud the government's intention to work with the provinces and the territories to sign the agreement that would provide what is called a universal single-payer first dollar coverage. We applaud that and the plan to allocate that funding to the provinces and territories is a goal in improving the cost, the coverage of medicines for selection of drugs, diabetes drugs. However, we're very concerned about the federal government's proposal of a single public payer approach to deliver pharmacare, because we fear that this could crowd out private payers, which currently cover the majority of Canadians, including 1 in 3 seniors. CARP believes this would not be of interest to older Canadians for a number of reasons. First of all, a single public payer system would make it harder to access many of the newest and most effective treatments. Public drug plans are notoriously slow in covering new drugs and much more limited in terms of what they offer than private plans. As well, a good example is the list of the diabetes medicines. It's been mentioned before that the federal government is planning to cover. It's very limited and doesn't include the very latest treatments used by seniors with diabetes. Secondly, offloading all Canadians onto a single public plan could lead to serious disruptions. There were challenges a few years ago when Ontario moved to all youth under 25 to OHIP or OHIP Plus, the government administers plan. During that transition, many Ontario kids lost coverage for their medicines that were previously available to them under private plans. A reform of the current drug insurance system could lead to similar challenges with potentially devastating consequences for many older Canadians who rely on their medications and can't afford any disruption in their access. Third, most Canadians already have coverage for targeted diabetes and contraceptive medicines through private plans. The government's plan to invest $1.5 billion over 5 years to provide coverage to these Canadians would be a waste of public funds. There are many other areas where additional federal funding could be put to better use, including addressing the challenges of the current system, such as the high out-of-pocket expense for medications due to insufficient spending and coverage of medicines by public drug plans. This can be a major financial burden, particularly for seniors, many of whom, of course, are on fixed income. The Canadian Association of Retired Persons and our members, and we do survey our members on a regular basis, and they are telling us that they believe we could build a successful mix of public and private programs to achieve universal coverage through a targeted approach that focuses on those most in need, the uninsured, the underinsured, and those facing affordability challenges. We've already seen this model successfully implemented with the federal government funding agreement with Prince Edward Island. The province provided the provincial funding to help expand a number of drugs it covers and to reduce out-of-pocket costs for island residents. This approach, which builds on existing pharmacare programs, will likely be easier and quicker to implement and than significantly reforming the current system. Canadian seniors want to see timely results that make real positive difference in how they access medicines and ultimately manage their health conditions in order to enjoy longer and better lives. Thank you for this opportunity.
Thank you very much, Mr. Van Gorder. Next, over to Diabetes Canada, Mr. Glenn Thibault, Executive Director, and Russell Williams, Senior Vice President, Mission. I'm not sure how you plan to divide your time. Okay, as parliamentarians, you know the drill. Mr. Williams, you have the floor.
Merci beaucoup. Thank you very much, Mr. Chair and members of the committee. Diabetes Canada has long advocated for the over 4 million people with diabetes for improved access to medications, devices, and services at the federal, provincial, and territorial levels. The goal of Diabetes Canada is to improve the quality of life for people living with diabetes. Diabetes Canada applauds the government's intention to include diabetes medications and devices in the initial scope of the pharmacare plan. In fact, we see this as another step in building from the diabetes framework that was tabled last year. And thank you, MP Sidhu, for your leadership in that. But there is an urgent and pressing need for those who are and underinsured. With broad consultation and careful implementation, this could represent a significant step towards reducing barriers. Providing comprehensive coverage and patient choice, continued improvement of care, and a robust consultation system are our 3 key recommendations. We recognize that there are significant gaps in coverage for some people living with diabetes, and our belief is that any public coverage should focus on addressing those gaps. As a first principle, we believe government should focus on the and underinsured individuals. But the approach to diabetes management must also be comprehensive and aligned with the Diabetes Canada's clinical practice guidelines. These guidelines are created by the country's experts and are one of the foundations of which physicians make informed decisions about patient care. Unfortunately, the formulary that was tabled along with the law by the government is not aligned with the clinical practice guidelines or the NIHB program and is limited in scope, excluding several key newer treatments while including older and outdated treatments. We have produced a comparison of the proposed formulary of the CPGs and NIHB program. This document demonstrates that for many and underinsured individuals living with diabetes in Canada, most of the commonly prescribed medications would not be covered by the proposed plan. This is why filling the gaps to focus on the and underinsurance individuals to start with is so critical. We met with the minister yesterday, and he confirmed, though, that this list will grow and will move forward in terms of greater coverage. We have to remember what we're talking about here, too. And let me underline and I know you all feel this, but the human reality, we're talking about the most vulnerable. Our 1-800 line that is open to all Canadians, we get a number of calls regularly. Senior citizens that are choosing between rationing their drugs or going without. People not taking the right amount of their medication because they can't afford them. Recently, we were getting calls about people were concerned about their private insurance, whether they'd lose it during the transition of this law. We again were assured by the minister when we met with him yesterday that people would not be shifted off their private insurance. These are two of the fundamental questions we had. A further recommendation was an adoption of our principle of continued improvement and access. Our CPGs have shown new data continually indicates improvements to services, care, products. A pharmacare system must incorporate the principle to ensure new techniques and products which are more effective, and when they're more effective and they become available, they get incorporated into that plan. The system should actually welcome diverse approaches, creativity, including private insurance, while seeking universal coverage. Every province and territory has a distinct approach to its public formularies, and pharmacare should be no different. We already heard, but Quebec's hybrid model is an interesting example, a good example to consider. C'est un système universal, mais c'est un système mixte avec le public et le privé. We must ensure that all individuals do not lose access to drugs that they are already covered by private plans and not included in the formulary. Unfortunately, we've seen examples of that issue in the past. So therefore, we are calling for a do no harm inclusion in the law to safeguard existing access to medications and ensure persons living with diabetes can continue to access the treatments, the latest treatments and care. With these recommendations in mind, we believe that Bill 64 needs a process of evaluation and practical analysis to ensure we set up the most effective system. That is not just a debate about ideas, but it's a practical analysis for the effective system to improve access to medicines in people with diabetes. We call for a more robust and transparent consultation process in the next steps of this law with people, patients, people with lived experience, healthcare providers, drug plan managers, researchers, provinces, territories, and the Indigenous communities. We encourage parliamentarians to carefully ensure that this emerging national pharmacare delivers on its promise of improving access, and it ensures that no one gets left behind. We appreciate the opportunity to share our ideas and are certainly open to questions. Merci beaucoup.
Thank you, Mr. Williams. And finally, Smart Health Benefits Coalition is represented by Caroline Egan. Welcome to the committee. Ms. Egan, you have the floor.
Thank you to the committee for the opportunity to appear today. The Smart Health Benefits Coalition are a united advocate for smart, innovative solutions that result in timely and positive change for Canadians. Through our 7 member organizations, our on-the-ground advisors support and advise more than 65,000 plan sponsors with their employee drug plans, including over 4,800 union plans. Together, our thousands of advisors across Canada support robust benefit plans for 10 million Canadians and their families. Let me summarize our top-line perspective on pharmacare. We fully agree it is unacceptable that Canadians are currently living with little or no coverage for essential medications, stuck in the gaps between public and workplace systems. Even though 97% of Canadians have some drug coverage, nearly 1 in 5 Canadians still report having some difficulty affording out-of-pocket drug expenses. We recognize this is an affordability and access challenge that needs smart solutions. Canada can work with provinces to better solve these challenges faster and more cost-effectively by focusing net new public resources and policy energy on filling the gaps and taking a progressive approach to affordability. We believe that universal pharmacare can be done with less money spent, with better and quicker access to drugs, and with less disruption to Canadians' healthcare treatment plans if the government does this through a targeted multi-payer system rather than on its own. We believe there are a few critical considerations that need attention. A universal single-payer first dollar coverage model will require taxpayers to carry the whole cost of drugs and fees. Currently, employer plans pay over $20 billion in drug claims, providing medications to Canadian families every year as a well-functioning part of our comprehensive healthcare system. When looking at the challenges facing Canadians, spending precious new healthcare dollars where workplace coverage already exists is an expensive, missed opportunity. The biggest cost pressure and pain point for any Canadian, whether you have coverage or not, lies in high-cost therapies associated with conditions such as cancer, Crohn's disease, cystic fibrosis, and many more chronic and rare health conditions that have innovative, life-changing drugs. These cost pressures are potentially devastating and deserve a higher priority within the pharmacare discussion. We've recently been very concerned to see comments by the government stating that Canadians would retain their ability to choose a new public plan or their existing workplace plan. Like other stakeholders, we are seeking clarity what universal single-payer first dollar coverage means. This is important, as from our industry perspective, this term means that if the public system pays for a certain list of drugs, under the Health Canada Act, employer plans are not permitted to pay for those drugs. The result would appear to have the unintended consequence of impacting the PBO's estimates, which currently assumed continued employer coverage, resulting in savings of $4 billion per year. This is critical to resolve, and if the intent is in fact to permit Canadians to choose where they get their coverage from, then we believe this part of the bill needs to be written with clarity and no room for assumptions. Let's go over some smart solutions we're proposing. Let's use net new taxpayer funding in a way that gets coverage and cost relief to those in need. Absolutely. Require a common minimal formulary for all employer-sponsored and provincial drug plans to create predictability and a floor of coverage. Work with provinces to create a coordinated national system of rare disease and high-cost drug coverage. Update the Canada Health Act and work with provinces to include common out-of-hospital therapies, for example, cancer treatments. Now, specifically, we have proposals to strengthen the bill and framework. First, ensure coverage available to Canadians regardless of province. Without intervening in the core aims of the bill, we propose an amendment that would provide for the Minister of Health to enter into secondary negotiations with province in the event that a province were to formally reject the single-payer pharmacare. This should allow for Canada to negotiate and enter into an agreement with a province where universal, no-cost treatments are made available without the restriction of a single-payer first dollar model. Second, examine opportunities to explore pricing reductions. Third, provide Canadians with a cost-benefit analysis prior to further steps. We propose an amendment that would ensure public accounting and cost-benefit analysis prepared and released prior to any consideration of an expanded single-payer system. Canadians deserve to know the facts and costs before governments take further steps that may irrevocably impact their ability to access and afford a wider range of medications currently provided under workplace plans. In closing, I want to thank the committee for the opportunity to appear today and happy to answer members' questions.
Thank you, Ms. Egan. And we're going to proceed now with rounds of questions, beginning with the Conservatives. Dr. Ellis for 6 minutes.
Thank you very much, Chair, and thanks everyone for being here on this important topic. Ms. Egan, I'll start with you. It's interesting. We're going to be here, and not that I mind being here with my colleagues for 15 hours to talk about this. And I guess my plea is it's just not enough. When we see legislation like this that has the potential to impact the future of all Canadians in terms of accessibility to funding for medications, it would seem to me that this is a pittance amount of time to spend debating this and how it should be rolled out. And I wonder if you might have some comments around that and the consultations that you have had with respect to this bill.
Yeah, I would thank you for the question. I would say that indeed this is worth time well spent. We look at what a great risk it would be to make decisions around people's health care, people's drug coverage, that impact the lives and the productivity of our workforce and our seniors and those who are underserved. It's important to do this right. And with that said, this is why the Smart Health Benefits Coalition, we are advisors who work in offices, in machine shops, in union shops, in every aspect of every business in Canada to help them design their benefits package. And we see every day the pain points and what works well as Canadians navigate between the public and employer systems. So we have great insights that we would love to spend time and help us make the right path. We all agree in the destination, but the path of getting there is so important, and to have communication and clarity around this is essential.
Thank you very much, Ms. Egan, and through you, Chair. Ms. Egan, do you believe that that there are people out there who are afraid that they will lose their private coverage should this national universal single-payer system come to existence?
Absolutely. I think we can point to even recent examples with our national dental plan. I think there are some great things there in place where people had no coverage. We did fill those gaps. But there have been thousands of our advisors who have received thousands of phone calls and engaged discussion with the misperception that people can go ahead and cancel their plan and essentially replace it by the free plan, not knowing what is on that list of coverage and who is intended for. My own mother, who's turning 80 this year, got her letter, and she was completely confused and figured she would cancel her plan and have free coverage with everything included. Luckily, I'm in the business and could explain it to her. But it is a risk. It's a great risk of employers and Canadians thinking they would lose access to a longer list of medications where their health is stable on the treatment plan that they have been prescribed. And losing that access puts everything at risk. It puts the sustainability and health of our Canadians and families and our workforce and productivity at great risk.
Thank you very much. And through you, Chair, Monsieur Morin, merci beaucoup pour votre témoignage.
Thank you very much, Mr. Morin. In Quebec, are there concerns about the closures of rural pharmacies? Yes, there is great concern. We saw what happened in New Zealand. After a universal plan was put in place, about 371 pharmacies were closed. Therefore, in Quebec, we are concerned that if there is not a blended system, it will impact pharmacies significantly and lead to closures. It may also affect pharmacies' profitability. They may end up becoming centralized in urban areas rather than rural, indeed.
Il y a quelques mots techniques.
Now, there are some technical terms in what I wish to ask, and I will have to say them in English. I'm sorry.
Expanded scope of practice for pharmacists. Obviously, as you mentioned in your opening remarks, that has become an incredibly important part now of, sadly, delivering primary care in Canada because of the crumbling healthcare system, which is on the brink of collapse. I don't think that's too much to say. But perhaps, obviously in this bill, there's no mention of funding of the expanded scope of practice. But maybe on behalf of your members, you could explain to Canadians how important that is now to the delivery of care in Canada.
Oui, merci pour la question.
I'd like to thank you for the question. Now, of course, there has been different legislation in Quebec that has expanded the scope of practice for pharmacists. This has happened on at least 2 occasions. There have been 7 million clinical services over the past year including caring for chronic illness, vaccination, and more autonomy for pharmacists. They can prescribe medication for minor conditions, for example, women's UTIs and other common ailments. We also hope that in the near future we can further expand our scope of practice. But these activities need to be funded in some way. Currently, they are funded by drug distribution. So distributing this medication means that pharmacists can carry out clinical activities. We believe it's essential to maintain that scope so we can continue playing that role. Over the last few years, we're having to do more and more with fewer and fewer resources. There's a labor shortage, yet needs are growing. We need to maintain this stability in order to continue playing a role that meets patients' expectations in Quebec.
Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for being with us. I really want to say thank you, everyone who's working on the ground, especially Diabetes Canada, JDRF. But my first question is to Mr. William. Mr. William, as we work together from many, many years, especially, framework for diabetes. Thank you, the work you are doing on the ground for the people living with the diabetes, especially in Brampton, even though I just want to acknowledge that you're also sending reps from Diabetes Canada to educate people. Thank you so much from bottom of my heart. My first question is that, on the implementation of the National Framework for Diabetes. We know that coverage of diabetes medications and devices is an essential component of the framework. Could you give a brief update to this committee on the implementation of framework, and also what recommendation can you give to this committee about the best way the Diabetic Devices Access Fund can serve patients with diabetes?
Thank you very much for the question. The framework that I referred to actually has improved access for medications and devices as one of the 6 main components. Across the country, the provinces are working on, to their own levels, implementation of the framework. I don't have time today to go into it, but I could certainly give details to the committee later on. So there's a real engagement of provincial health bodies to take the 6 pillars of the framework and implement them. So I see this as a part of the next step. Now, how we do it is still, there's a lot of questions, and I think that you talked about in terms of education. I think a lot of people around in this country don't know how the healthcare system works or how pharmaceuticals are delivered. And I think there probably is a need for greater clarity. I'd also very much encourage that, and the next phase of this law is that we take the discussions of the framework that we're doing and add concrete discussions with the provinces of how pharmacare would work within that context.
But as the minister said yesterday, the bill will not impact access to private insurance, and people with diabetes will continue to have access to the full range of medication that is provided to their current insurance plans. This will add to the existing plans and does not take away anything. What do you think about those comments from the minister?
Well, at our meeting, thank you, Mr. Chair. Thank you very much for the question. The meeting with the minister, those words were very reassuring, because when you take a look at the bill, there's a number of interpretations that we've heard about today that has gotten a great deal of concern. Excitement in some areas and concern in other areas. So the clarity from the minister is important. We did also talk about the list that the government tabled. Is certainly not all-inclusive and certainly doesn't reflect the clinical practice guidelines that the Diabetes Canada creates with experts. And he assured that this is a minimum list and that we'll start to work on. We've supplied the committee members with a comparison between the clinical practice guidelines and Bill 64 list, as well as the NIHB list, which is a list of the government. So ultimately, the care and management of diabetes is not one size fits all. It's very individual focused, as you know, and that we have to make sure that we build a program that will, on one hand, not just seem that there's a certain level of cover, but it'll actually be effective cover for people with diabetes.
Thank you. And it is important to acknowledge, for the education, but also important to acknowledge the leadership of some provinces that work in implementing the national framework for diabetes, and some provinces like Quebec, you already talked about in your testimony, have a good hybrid model towards pharmacare. And let's talk about the human cost for patients. It's clear that patients just want the system that works for them, but from the meeting, we understand that we need to work with the patients during the rollout. How would you like the Government of Canada to approach the outreach component to educate patients with the diabetes on the rollout to the pharmacare program?
Thank you for the question. This is fundamental. We have to have patients at the table and being fully involved in the discussions. That hasn't happened too much at this point. And with the limited debate, which as a former politician, I'm concerned about limited debates, but that's what this decision was made. Now we have to get out in the community and we have to get concrete. We need to talk to patients, and I would say we should set up a large education program. We should start a full engagement discussion. Diabetes Canada would be pleased to help. But we should also sit down and, again, former provincial politician, we should talk to the provinces, say, here's the direction we want to go. We want to try to fix this for vulnerable Canadians. How would you do it in your province? I mentioned one in terms of Quebec, in my province that I come from, but we work with each and every province, and that's why I mentioned in my remarks we should build on the creativity and diversity of our healthcare systems across the country in both the provinces and the territories.
My next question is to JDRF. Ms. Dennis, not so long ago, you joined me in Brampton, where 1 in 5 Canadians live with diabetes for the 3rd annual Diabetes Day flag raising. It is great to see you again virtually. My question is to you. Investment into research allow innovative companies to provide new solutions and devices such as pumps, continuous glucose monitor, and other devices. The Diabetic Devices Access Fund is the key to unlock access to newest technology for diabetes patient who has diabetes. How can this fund best serve Canadians?
I'm sorry,
Well,
Ms.
first,
Denise,
it's very nice to see you again,
a
and
brief
thank you for
response, if
the.
you could, please.
Sorry. First, thank you for the question. I agree. The Special Devices Fund is critical that we get this right. Access to continuous glucose monitors for people with diabetes is so critical. It improves health outcomes and it actually reduces complications. It will reduce our long-term healthcare costs if we can get better access to continuous glucose monitors for Canadians. So we would propose an open engagement with the Minister's office as well as with the provinces to see how we can get more Canadians having access to CGMs. It is critical, and we will have better long-term health outcomes. Thank you.
Monsieur Blanchette-Jonca, pour 6 minutes, s'il vous plaît.
6 minutes, please. Mr. Blanchette-Jonca. I'd like to thank the witnesses for being here today. So I have a question for Mr. Morin from the Association Québécoise des pharmaciens propriétaires. From where you sit, you have an excellent understanding of the costs of certain drugs. People who are currently under a Medicare plan, will they be able to continue using it? Yesterday, the minister seemed to say yes. A credible witness from the Canadian Medicare Association, Medical Insurance Association, said that it was possible. Now, in your brief, it said that if this were to take place in Quebec, the viability of the system might be threatened. Could you please tell us what you think of that? Well, thank you for the question, Mr. Blanchette-Jonca. Yes, to think that private insurance could simply act as a complementary insurance, there's not the viability that we need to see. I'm not a specialist on insurance, But if we look at what's going on in Quebec, in the system there, I think it just wouldn't work. This is a system that functions with blanket care. Now, we know that there are also SMEs that may use collective insurance. They don't have to. They could use the public system, but they often end up with a collective system, and I think that's a good thing. I think it allows them to offer the best possible solution to their employees. I think that system should remain in place. Additionally, very often these plans offer broader coverage than the public system. In Quebec, however, we already have a public system with broad coverage. If we compare Quebec's diabetes formulary to the one in the national plan, there's a big difference in accessibility. That's what I would say. So if I'm understanding you correctly, if hypothetically we lost the private plans, or even if they were kept hypothetically, is it realistic for the government to proceed with a zero deductible? And if the same formulary could be offered? Answer, I don't believe it's realistic. Question, why? Answer, because of the cost of drugs, the increase in the cost of drugs. Choices will have to be made if exhaustive coverage is offered, if it's 100% under the public system, then the government will have to make difficult choices. Given that technology is changing quickly and new medication, very expensive medication for rare diseases and chronic diseases are coming on the market, we know that some of these new drugs are really miracle drugs, but they're very expensive. And when we're looking at the overall system, well, I can see that there might be some issues. Thank you very much. Coming back to what you mentioned earlier, you mentioned earlier how important it is to have pharmacies in remote areas. I represent dozens of communities in the Bas-Saint-Laurent, and I know that it's very important to have pharmacies. You mentioned that currently, what's proposed by the federal government could threaten community and remote pharmacies. You said that 371 pharmacies closed in New Zealand after similar legislation was passed. I'm very concerned about this. We need the services to be available locally. We want to keep people in their communities, and we also know that we have the second most aging population in Quebec in my community, and overall the population is aging. What are we to do about this demographic burden? Answer, I don't think we should put undue pressure on key stakeholders like community pharmacies. You mentioned the Bas-Saint-Laurent region. And indeed, we offered a frontline one-stop shop for so-called orphan patients. We helped them to get pharmacy services when possible. And that's a great example of a case where pharmacists can offer services. Even though these clinical services may not be appropriately remunerated in themselves, the pharmacy can still carry them out because overall they're in good financial health. But changing the system would mean that some of these remote pharmacies might have to close. Currently, there are about 8,000 drugs on the Quebec formulary. It's not perfect, but it's going pretty well. 8,000 is a lot. Might there be the risk of losing some of that coverage under the proposed federal program? Answer, if we look at Quebec's list and we compare it with the proposed ones, we can see that although it's not final, well, millions of diabetes prescriptions might be lost. A significant percentage of patients might have to change medication. Of course, we can't do that. We see that already in community pharmacies, they run out of certain drugs on a regular basis. And if you add to that dramatic coverage changes, that could be catastrophic for the health of Quebecers and Canadians. We need to make sure that the list includes Quebec's list. Even though Quebec is generous when it comes to diabetes medication, well, it's necessary for the reasons that my fellow witnesses have raised. After all, there are individual differences in how diabetes is treated. The fact that there's such variability in covered drugs, that's essential to help support people's health.
And next, Mr. Julian, please, for 6 minutes.
Merci à tout un témoin.
I'd like to thank all of our witnesses. Everything you're saying is extremely interesting. I also have a question for Mr. Morin and Madame Pelletier. Pharmacists play a key role. That's clear in the future of pharmacare. Yesterday, a large group of Quebecers, including a number of unions, Health Professionals Union, Consumers Union, and many other organizations, bringing together around 2 million Quebecers, they said the following about the situation that is currently in place in Quebec. They said that the current Quebec Medicare system does not guarantee reasonable and fair access to medication for everyone. There are many fees. And because of those fees, there can be a discouraging effect. People may skip doses or not take their medication at all because they just don't have enough money to buy them. And the increasing price of medication is placing pressure on the private system, which means that some people are losing their coverage. That is why these groups are asking parliamentarians to pass C-64. Now, you raised the matter of the lists of medications. That's something that will be up for negotiation with Quebec. We've seen that having a single-payer public plan in other countries, we've seen other cases where pharmacies did not close. Is your message today ensuring that everyone has access to the medication they need? But that we need to be extremely careful in our negotiations about how pharmacists will be affected by the universal plan? Mr. Julian, thank you for the question. First of all, before thinking about pharmacists, of course, we need to ensure that everyone has coverage. But currently, no one can pay more than $996 a year. Deductibles and copays are capped, regardless of the public or private nature of the coverage. Low-income individuals pay nothing. And so we know that for others, the limit is at $996 a year. The private system is on a yearly basis, the public on a monthly basis, but I think it's better separated it out by month because $1,000 might be too much for someone and might lead them to not take their medication. But $90 or $100 a month can be reasonable. I don't think the solution is making things free for everyone, but instead to educating people with a certain level of income that medications are critical and that they should give them the importance that they deserve, and that if they're able to pay, they should prioritize taking their medication. And then for those who can't pay and who are under the public system, then we must ensure that they have full coverage with no disincentive to taking their medication. Then we agree that the status quo is not acceptable.
You, Ms. Dinez, we had very compelling testimony yesterday from Mike Blesky, who is a young person with type 1 diabetes. He talked about what happens if he loses contracts. He talked about, well, I go into my line of credit to keep paying for the medication that keeps me in health, in life. But when I asked him, well, what happens if the contracts don't come? You can't go into the line of credit. He talked very, I thought, movingly about within 24 hours, he could find himself in the hospital within days facing amputation or worse. I'd like you to tell us what happens when people can't afford to pay for their medication now. When it comes to diabetes, what are the impacts? When you can't afford to pay for medication, what happens to you?
First, thank you very much for the question and for bringing in this areas of focus. I agree. It is critical that patients have access to medications and devices they need. For type 1 diabetes, this is a matter of life or death. They don't have a choice. Think of insulin as like air. They need insulin to stay alive. So to your question, what happens to the individual when they can't afford their medications anymore? They ration. They don't take enough. That leads to worser health outcomes, more complications, and that actually costs the healthcare system more money later down the road. So I think it's important to think about the young person entering the workforce who no longer has coverage under their parents' plan, who's choosing their profession based on the benefits programs that are being offered that can cover their medications. So it's critical that Canadians living with type 1 diabetes have access to medication to control their diabetes, which eventually will prevent long-term complications.
Mr. Thibault, I'd like to ask you the same question. What are the impacts when people can't afford their medication?
Thank you for the question. Through you, Chair. Very, very similar to what our colleagues at JDRF are talking about. Someone who lives with type 2 diabetes will also have serious complications if they can't access the medications that they need. As a person who also lives with type 2 myself, I was diagnosed in 2016 when I was an elected official, and learning the process of what type of medications you need to go through. And I've been through 3 or 4 different types of metformin before I was able to get onto the right one. And that's why we've talked about choice and making sure that choice is available to everyone who lives with either type 1 or type 2 diabetes, because the importance of making sure that we can avoid all of those complications that we know that can happen out there. And I know, Mr. Julian, you've talked about, is it Amber in your riding, who spends $1,000 a month?
Thank you, Mr. Thibault.
Are we out of time?
We are indeed.
Okay, well, we can talk about that next time.
Dr. Kitchen, please, for 5 minutes.
Thank you, Chair, and again, thank you to everybody for being here so quickly on such short notice, and for many of you who provided us with briefs. I greatly appreciated to see that in advance, and to have them here to unfortunately, I'd love to go over each one of them with every one of you individually. It is appreciating, and so I think I'm trying to be as quick as I can to ask questions. And so, Mr. Williams, you've indicated to us that you met with the minister yesterday. Did the government actually come to you before as they were standing and setting up this plan any time before that, or was it purely an opportunity to speak with the minister yesterday?
Question. We talk with the governments regularly, mostly on the implementation of the framework. We did not talk about the specifics of this bill before.
Thank you. And we've heard that from many groups, in particular yesterday, where there's been a lot of concern about no one discussing it. It's from the provincial health ministries all the way up to individual, whether it's diabetes, et cetera, and experts along those lines. So appreciate those comments. It's part of what you sort of talked to is you said when your conversations with the minister, and the minister was here yesterday, and he basically said that, trust me, everything's going to be good. And apparently from what I'm hearing you say, that's what he said to you. Trust me, it's going to be good. But this is from the same government that said that the carbon tax would never go above $50, and yet they campaigned on that in the 2019 election, and now it's going to be up to $170. So I guess the question is, how trustworthy do you see, and would it not be better to have something in the legislation that would support and provide protection from that?
Thank you for the question. And one of the things we talked about yesterday, and we've supplied it to all the members, is actually a comparison of the list provided by the government and our clinical practice guidelines to say that there's work to be done on this. We've also supplied all the list of what's happening in each and every province. Where I'm kind of leaning at, and I'd like to have all the answers, and we've been working at this for some time, but I'm leaning towards trying to move this forward for the most vulnerable people as soon as possible. And one of the things we have to do here is we've got to get answers to those questions, for sure. There's other stages of this law. There's going to be negotiations with the provinces. And should we move on in this? I'm not entirely comfortable with this. But on the other hand, for the people that we're trying to serve, is it worth trying to move forward on is there enough checks and balances for it? But I understand your question. We put those questions and we'll share any of the answers we get from the
And I
government.
appreciate that comment. And you did mention where you talked about the uninsured and the underinsured. And those are aspects of things. And I do appreciate your document because I do have it here. And you know, it's interesting. I am a type 2 diabetic. And to you, Mr. Thibault, I too went through a number of aspects, and my wife as well, on what metformins would be there. And I appreciate the comments in here where you've listed the differences and where you've indicated that the FINH is, or basically the plan that they have is better than the plan that was proposed by the government. And we got that information as well from First Nations yesterday to indicate that that avenue is there. And basically the clinical guidelines are there, which are very appreciative too. The challenges, and I see where, for example, under Quebec, where we see the listings here, they're either restricted, in other words, they need to have permission to get them, or they're listed. And they're the most prevalent of all the provinces. In Saskatchewan, and I'm on Jardiance, and ultimately it indicates that it's a restricted, and that's true. I need to get permission from my doctor in order to get that aspect of things. Those are huge challenges that are there, and where we don't have doctors available to provide that even to provide such that we can get that done. So the challenges we have as we move forward along that is the plan that's being proposed basically is a very basic plan, but there's no avenue to indicate that it would change. There's no avenue to indicate that as more, and that's what we heard from different people, is that as medicines improve, that list would be changed. Do you not see that as well as something that is an amendment that might be available that we need to be putting in this legislation to make certain that that is complied with?
Thank you very much for the question. And that's why we put in our second recommendation, the principle of continued improvement of care. We have to make sure that as new medications come up, and our clinical practice guidelines change from time to time as we get new evidence, that we have to have a system that allows for it. And it shouldn't be just the system of the older medications, but it should have a capability of it. So our recommendation would be that principle would be built in. And again, discussions we had yesterday, we expressed that. We understand that's there's an opportunity, and ultimately, it's discussions, and I hope every province will also embrace that principle, and that will build a stronger system other than that base list that we saw tabled with the government that the minister once again said that will grow, but we'd like to see how much it will grow in the discussions with those that know. And again, I really would like us to get to the next level so we can have discussions with the healthcare providers to understand some of those questions. Thank you very much.
Thank you, Mr. Williams. Next, Dr. Pawlowski, please, for 5 minutes.
So C64, except for diabetes medication and contraception, does not create a single-payer system. We don't know what the national pharmacare system is going to look like at the moment. Not necessarily, by the sounds of it, a single-payer system, but Ms. Egan, in response to the idea of a single-payer system, you kind of said, well, this is wasteful because all Canadians would have to pay for it with taxes, which is true. But you say, well, right now, many Canadians get it as a benefit from their employer, right? But it's not like that's free, right? That's part of your pay. You get paid a certain amount of money, but you get some benefits. It's a cost to the employer. And if the employer doesn't have to pay that cost, presumably you would get more in your salary, right? And if the government can have a system that is cheaper to run, and there is some indication that a government-run system, because of economies of scale, a nonprofit system, the government could provide that system cheaper than the employer could, that would be of net benefit to Canadians. Would that not be the case?
Well, what I would like to highlight here is that today it's $15 billion. So how much cheaper could you turn that number into? That's what's being paid by employer plans. Secondly, I would say that 4 out of 5 Canadians are enjoying that system without any reported incidents or challenge. we agree. Let's get the coverage. Let's not take the money where it's working well. Let's leave that in place and allocate those dollars, those extra dollars, to those that have no coverage or those that struggle in any capacity, whether it's 20% of a $100 copay or 20% of a $10,000 copay. People are struggling at both ends of that spectrum. But the ones where 4 out of 5 it's working for, let's leave that in place and leave what's working. And let's get the dollars allocated.
Well, although you may get benefits as an employee, those plans that are private plans, a certain amount of the money goes to the profit for the provider, right? And instead of that money going to the profit of the provider, perhaps that money could be used in order to provide better health care, pharmacare for all Canadians, if there is efficiencies in having a government system. Is that not the case?
Well, I can tell you from working in this business for 28 years and having done the analytics on renewals line by line, the profit margin would be surprisingly lower than what you're thinking. A lot lower.
The profit margin
for benefits, for running a benefits program. So that money alone would not even put a drop in the bucket to what we need to achieve as a country. We need to work together in a multi-payer system to achieve. And if you could allow me a brief example here. I'm going to say there's a patient A with a $100 claim, no coverage. Let's get them that $100. Patient B has 80% coverage through their employer. Employer plan pays 80, the patient pays 20. Now that patient is struggling. Let's figure out how to get them that $20. In the third example, if I may, there's a third one where there's an 80% coverage and the employer pays 80, the patient pays 20, 4 out of 5 people, that's working great. Why disturb that?
So,
the last one is a fourth scenario where people have 2 spouses, 80%, and they coordinate, there's 0 out of pocket. Works great. Scenario 1, single payer, government pays 400.
Can I interrupt?
Scenario 2, it's 140. So
I want to ask a question because pretty well everyone said a limitation of a single payer system is, and I would challenge this, but they all say, well, those systems are all kind of limited in what they provide. How about if you want a newer medication? How about if you want a brand product? That's not allowed in those kind of single payer systems, but it could be. There's nothing to stop it. But how about there's nothing to prevent an employer, if there's a single payer system, for an employer to offering additional benefits, so kind of a top-up system, just as now as through Canada Life, I think, if we go to the hospital, because we get Canada Life insurance, we can get a single room instead, or a room with one other person or something. That's a benefit that you get from Manual Life that you would otherwise not get. But that's what's offered. So couldn't an employer offer a system that provides that kind of top-up coverage, so there would still be that choice if people wanted it? And a number of people have all kind of said, well, that's the problem with the single-payer system.
So here's the challenge.
A brief answer, please.
Challenge lies in confusion. Look at dental. How many people think that the coverage is the same, and they go to cancel it, and then you're left with nothing. So this way, shifting that cost entire to the public system would be at great risk. We have a longer list of covered medications that get faster under the employer system that we need to protect and have in place. We need that system to help people that can't afford both base medications and those high costs. Let's keep innovation coming to Canada with those therapies for cancer and other conditions that are costing tens of thousands of dollars for patients that are struggling to afford even a 10% copay. Thank you.
Thank you. Monsieur Blanchet-Tionca pour 2 minutes et demie.
Merci, Monsieur le Président. Je poursuis.
Thank you. I'd like to continue with Mr. Morin. Mr. Morin, according to some of my parliamentary colleagues, the status quo would cause a catastrophe in Quebec. So my question to you is whether it wouldn't be better to be able to opt out unconditionally so that we ourselves, as we've been doing for nearly 30 years, improve our pharmacare system. Yes, and that is what our organization proposes. Our system isn't perfect, as I said earlier. In some cases, people who are privately insured may have to pay the $1,000, so we need a system that protects us against that. We may need other measures as well. We've heard that it can be very difficult for rare drugs, and sometimes it can be hard to find a doctor. It can be very hard for some patients. Therefore, I think we need to reduce silos and make it easier for these patients to access care. This is something we could address within Quebec. Now, in addition, in Quebec, we have the INES, the Health Excellence Institute, which takes decisions on what should be included in the list. As a pharmacist, I would say that 99.9% of the time I support these decisions because they are not based on logistical factors having nothing to do with the data, but rather they are based on the effectiveness and relevance of the drug, because we know the pharmaceutical industry can accomplish a great deal, but sometimes certain drugs may be more expensive, and that institute carries out the analysis in great detail, and that's all part of what makes our system good quality. Now, Mr. Morin, according to a report, 94% of Canadians agree that we should increase community-centered health services. You talked about that. We know that the federal government ought to pay 35% of the costs in Quebec, but is currently only doing 22%. Will that really enable community-based health services and pharmacy services to increase? Yes, in the proposed system, we only hear about distribution in pharmacies, not about services. But for example, young women coming in for contraceptives also need other services, for example, Plan B. These other services need to be appropriately funded in order for the system to be streamlined and to make sense. Thank you.
Monsieur Julien pour 2 minutes et demie.
Merci beaucoup.
2.5 minutes, Mr. Julien.
Thibault, you had just started to talk about Amber, who is a young woman with diabetes type 1, and I wanted you to continue informing the committee about her situation.
Thanks. Through you, Mr. Chair, thank you, Mr. Julien, for allowing me to continue, because the story that you have told about Amber, we could go into every single riding and every single constituency across this country, and unfortunately, we would have a similar story. And I know my colleague, Mr. Williams, talked about the calls that we are getting to our 1-800 line. So very similar to what Ms. Egan was saying, we have received calls from individuals who have no coverage, like Amber, who are spending, in her case, like you said, $1,000 a month just to get the care that she needs. And that's through devices and medications. We also have individuals who are living with either type 1 or type 2 diabetes who have private insurance. It's at, let's say the 80% level, and the 20% level is still difficult for them to meet at the end of the month. So they're rationing, as my colleague Mr. Williams also outlined in his opening statements. And so that's why we continue to talk about our 3 recommendations, because those are the key points that we think, the debate about what is universal, first dollar single payer, as Mr. Pulaski has talked about, hasn't been defined yet. We keep talking about the under and uninsured. We have an opportunity here, we being everyone at this table, diabetes organizations, contraception organizations, to actually look at making sure that we could fill those gaps. And if that isn't the right term, let's figure out what the right term is to make sure that the choice, the opportunity to continue to move forward is still there while we're figuring out how we make this work and the negotiations that happen with the provinces. So we talk about that fulsome consultation, that robust consultation that we would like to see with persons with lived experience, like myself, like Mr. Kitching, and everyone else across the country. Let's look at the comprehensiveness that, in the bill it talks about Section 4 and, looking at some of how the Canada Health Act can be included, and some of our legal interpretation talked about making sure that we look at comprehensiveness of that choice. And then, of course, what we're calling do no harm. Individuals that have a wraparound care, we need to ensure that they still have it, but let's not forget about Amber or about anybody else who we could talk to in any one of these constituencies across the country who need that support.
Thank you, Mr. Thibeault. Mr. Julian. Next, Ms. Roberts, please, for 5 minutes.
Thank you, Mr. Chair. And I'm going to ask, can I call you Bill? Oh, you're on mute, Bill. Okay. So I have 2 questions for you and would like some answers. So the first question is, many seniors in my communities have concern with the pharmacare plan, and I'll explain why. They're very disappointed in the dental plan, and they don't trust this current government to deliver any plan. They feel that they have failed them at every level. So I'd like to ask, in Ontario, seniors pay a flat fee and receive their drugs for the remainder of the year. So once a year, they pay a flat fee and they receive their drugs. How is this going to impact this? How is this plan going to impact the provinces and territories?
Thank you for the question, and through you, Mr. Chair, that's a key point, because they don't know, they're confused. I know that the seniors who are watching today, and I know many of them are going to see that if there are this many questions about the coverage of those with diabetes, what's it going to mean for the rest of us? Those of us with heart conditions, those of us with other conditions, people who need the coverage. And the confusion, the worriedness, they're fearful. And I'm not just assuming this. Our members write us weekly, if not daily, about their concerns. And why is this going so quickly? Why don't we know what's going to be covered? I had a woman call me the other day who said, my husband retired last fall and then he passed away. I still have his drug coverage, but I can't afford my payment part, but I'm told that I can't get rid of it and get on to the new program. Well, whether or not this is going to be changed or not in the future, that's the kind of thing that's worrying seniors. And when they hear a discussion like they're hearing today, whether they're in Ontario, in Nova Scotia where I am, or out in BC, they're worried about what they see as an incomplete framework.
Thank you for that. And you mentioned in your statement, in your opening statement, that the Ontario Plus plan and how it didn't have any benefits for young people. Well, we know what happened in 2018. The provincial Liberals got killed. What did you mean by that?
It meant that there was confusion in its operation when it first came into play. There were many people that fell between the cracks. Eventually, it seems most of those have been picked up, but there were people who were without the ability to get their medications from the time that the program is introduced until they got through the paperwork of getting it. And if seniors, if older Canadians have to stop even for a month or 2 months taking their medications, that's going to create very severe problems. We can't let that happen with this plan.
So I guess what we should do is put the patients back in patient care instead of the government. Would you agree with that statement?
I would absolutely agree. You know, what we have now, one of my colleagues pointed out, is kind of like a mismade quilt. It's a patchwork with gaps in it covering everybody. What's being proposed now is more like a burlap sack. It's kind of lowest common denominator with holes in it. We need a tightly knit quilt. That's what seniors are looking for and want to have. And whether or not the future will allow us to see things will be better and changed. Right now, they're really wondering why we're rushing this through with no consultation with our group and very few others.
Thank you for that. And I have a question for, can I call you Caroline? So the plan that you've explained to us, and you said that there's not a huge profit for companies. Can you tell me the difference between what the government is offering on the pharmacare plan and what it eliminates for current plans that people have?
Yeah, so when it comes to that list of drugs, I think this is what you mean. It would be far less extensive. We've been talking about that a lot today. So overall, province by province and employer plan by employer plan, it's a 40 to 50% difference in drug list of what is covered. So that's the main difference. Is there's a higher list of drugs, longer list of drugs, and with the money, if we spend it with smart solutions, we can get that right coverage to people for more health conditions, or a longer list within the fields of the conditions we're talking about today. What I want to also add is that, our advisors on the ground, the thousands that I mentioned across Canada that look after the 65,000 employer plans, we see province by province the models of how they are built today, what's working, what's not working, what are the pain points. And they look after not only the drug portion, but we're talking dental, vision, disability, paramedical, the mental health and wellness aspect of plans. So this is what is a comprehensive package that, again, 4 out of 5 Canadians are enjoying and seeing work well. Let's pay attention to the 1 in 5 that are having affordability and access challenges.
So
Thank you, Ms. Egan. Thank you, Ms. Roberts. Next up, Dr. Hanley for 5 minutes.
Thanks. Thanks very much for everyone's testimony and for the range of expertise and expert opinion that we have today. Really, really welcome. I've heard some maybe disparaging comments on the dental program. I just want to point out on that note that 100,000 Canadians have been served so far by the Canadian dental program, many for the first time. So to me, this is a model of success, early success of a great program. And I think there are some things we can emulate with the proposed C64. Mr. Van Gorder, I want to go back to you. Thanks for appearing. I'm mesmerized by your backdrop, I must say. I want to you wrote an editorial actually about pharmacare, and you talked about the successful collaboration between the federal government and PEI in 2021. And I wonder if you wanted just to comment briefly on that, on how that was a successful federal-provincial collaboration.
Well, thank you very much for the question, and through you, Mr. Chair. I think that we think that the agreement between the federal and provincial government in PEI was a model that many other provinces can emulate in taking the money that was available, examining exactly where the gaps are and the needs of coverage, and then applying the money specifically to those areas rather than trying to spread the money over like my burlap sack over the entire issue. It was a particularly focused and effective way of using the money, and we think that in the long run it will prove very effective for especially the seniors in that province.
Thank you, Ms. Egan. I was intrigued by your comment in your opening remarks about updating the Canada Health Act, and then you mentioned the importance of, for instance, coverage for outpatient cancer therapies. We know how big of an issue that is, but I wondered, have you done any analysis on what it would actually take to update? like, can you tell me a bit more about what your vision is there? I know that's outside of the scope of C64, but I am intrigued.
Definitely, I'm definitely would agree. Rewriting the Canada Health Act would be a task, quite the task. But what I can tell you is what we see boots on the ground would be.
Excuse me, Dr. Kitchen, please, on the point of order.
Mr. Chair, earlier when my colleague was doing her presentation and making a comment about Ontario and what transpired, a member from across the floor, Mr. Nakvi, basically called my colleague stupid, and I had asked that be stricken, and he apologized.
Mr. Nakvi, do you care to respond?
Chair, I would never call any member of this House or any individual by that term. I did not call the member that at all. If she feels that that was the case, I apologize. That was not my intention.
Okay. Thank you. Please continue, Ms. Egan.
Thank you for the question. I think this is an important part that we need to examine. And a brief example, again, boots on the ground example, I would say, is we had a recent patient who was in the hospital for chemotherapy, was prescribed a pill, their prescription, went outside of the hospital to fill it, came back in the hospital to be administered, and now what do we have? We have a $10,000 monthly bill where, according to the Health Act, it was prescribed in a hospital, went out to fill it, and now you have the public system and the employer system confused as to who should be responsible to pay. But the bottom line is a therapy like this, that is high cost, is allowing this person to leave that hospital and be productive at work and healthy long term. So this pipeline of drugs that is coming and available to Canada, we want to make sure that we can work together to cost effectively build a national strategy for high cost and rare disease. Thank you for the question.
Thank you. And I'm assuming I have preserved some time from that point of order. So
40 seconds.
I will just quickly go to you, Mr. Williams. You have a very interesting background from your experience with Innovations Canada, with Research Canada, also a political career. In the preamble, and I guess I don't have time to go over the preamble, but in this bill, we do talk about supporting modernization of the healthcare system with drug data, the improving coordination, that we talk about the national strategy for rare diseases. Is there room for improving collaboration, improving innovation within the context of C64? Do you see that there is potential there?
There has to be. We have to find the room to make sure that we continue to encourage innovation, research, development, as we're trying to make sure that on one hand we respond to the underinsured, but on the other hand we want to make sure that we continue to develop new treatments, new technologies that improve care. One of the challenges that you're trying to do is that's a balance that we're trying to work on. One of the things I think what we're trying to say is we would like to be able to help people get answers to your questions so that we understand how we're going to do it.
Thank you,
and I
Mr.
would
Williams.
encourage that we do that soon.
Thank you. We're almost at the hour, but not quite. We're going to shorten the last two rounds of questions, and then we'll thank and dismiss the panel. So the next two rounds will just be 3 minutes. Dr. Ellis is next.
Thank you very much, Chair, and thank you to the witnesses before we finish. Mr. Moran, I'd just like to ask a question. Are you still a practicing pharmacist?
Thank you for the question, Dr. Ellis. Yeah, I'm a pharmacist. I'm practicing. I practiced yesterday. I own a pharmacy in Montreal.
Thank you very much for that. And do you hear patients? I mean, has the issue around cost of prescriptions gotten worse in the last several years? People not being able to afford their medications?
Well, I've been practicing for 30 years, and I'm going to switch in French. It's going to be easier for me. We see.
Well, I find that the answer would be no. In Quebec, the plan went from being free at first, no cost, and then copay and deductible were added. That at times has been a problem. In my practice, I sometimes see social obstacles. People may not register because there are obstacles. So we have more logistical needs to help people get through the system rather than financial. Although such cases do exist, and I'd like to see innovative solutions to help people who are facing obstacles. I think social services would be the best solution.
Mr. Williams, you talked a bit about meeting with the minister. It's interesting, these lists that exist. Did you have any conversation with the minister? I mean, it appears they have no bearing on reality. So why did they create them? Did that come up in your conversation?
We rather chose to offer what we thought was a good list. And that's why the document that you all have in terms of the comparison of our clinical practice guidelines, as well as the NIHB program,
I'm going to interrupt you, only got a couple seconds, but did you talk about the list or no?
Yes, so.
But you didn't say why they created the list, if it has no bearing in reality.
What we said was it was not adequate compared to our clinical practice guidelines.
Okay, great. And thanks, Ms. Egan, to you finally in the few seconds we have left. We've talked a lot about public plans, private plans, et cetera. You have incredible experience with respect to this. Have you ever come across a public plan that is better than a private plan? And if so, what is it?
Within Canada?
Yes.
Okay. I actually would not be able to, I have not heard of one that is better, but I would defer to actually do further research. But to my knowledge, I've not been made aware of when you talk about list of drugs and time to access, I've not heard of a better public one.
Thank you, Ms. Egan. Thank you, Dr. Ellis. The last round of questions will go to Ms. Sido for 3 minutes.
Thank you, Mr. Chair. I just want to, my question goes to JDRF. Yesterday, we heard from Heart and Stroke, more than 600 people in Canada die every year from ischemic heart disease because they cannot afford the medication. And we also heard the testimony from type 1 diabetes patient, Mr. Blasky, who said that, the insulin is not luxury, it's a necessity. And we also heard the $1,600 a year per patient, they have to pay. So there's a lot of saving for this legislation. And Ms. Dennis, from our work on the framework, we know how important this legislation in the front of us to all patients and their families. What are you hearing from the young type 1 patients and their parents? What expectation do they have from the committee when it comes to C64? Can you explain that?
Thank you very, very much for the question. And I agree, diabetes is a very expensive disease to manage. And I think there's points in time with respect to their insurance coverage where it can be more costly. So this bill will help the uninsured and the underinsured significantly because, as I've stated, insulin is required to stay alive. It's not a luxury. It's not an add-on. It's something that's needed. And I think I encourage the committee to make sure that we're focused on first principles of providing better access to medications and devices that are required, and then look at the mechanism how. And that's how we're looking at this. What's our first principle here? To have better access for Canadians. So your question on what are people looking for? Better access, affordable and equitable. It shouldn't matter which province you live in or what age you are. All Canadians with diabetes should have access to the medications they require.
Thank you. And my next question is to Mr. Thibault. We know that education and awareness, because you know that type 2, living with that, how important is the education, especially in Brampton. I know you and me, we talked about that, and then Diabetes Canada is helping to the awareness campaign. So what you're looking at for the diabetic devices and also the education campaign when we are rolling out, what is your thought on that?
Thank you for the question, and through you, Mr. Chair. As an individual who also is fortunate enough to wear a continuous glucose monitor, it has completely changed the way I can manage my diabetes. It's allowed me to stay in the green for those of us that have it and understand what that's all about. And so making sure that we can get access to devices, and I know we're going to talk about the device fund in another time, that is an absolute game changer for people who live with type 1 or type 2 diabetes, and making sure that everyone can get access to that. And I think the device fund, that when we do have the opportunity to start talking about that in more fulsome discussion, because right now it's pharmacare, we are going to be able to rise all boats. Through the advocacy that we've been doing over the last year within Diabetes Canada, We have now provinces and territories right across the country who have some form of continuous glucose monitor or insulin pump coverage. That's great, but there are still gaps that need to be filled. And I do think having the device fund and then coming with the education component that will be needed to teach people to ensure they understand on how they can do this will be key. So, we're going to continue to advocate and do our job within Diabetes Canada to talk about the importance of devices and education and medications at the provincial and territorial level. We work with NIDA as well, who was here yesterday on the Indigenous component. We do a lot of work with JDRF as we met with the minister as a team yesterday to talk about some of the clarity that we're looking for on choice, and we were thankful to hear that. And as such, we'll continue to be a strong voice for the people who are living with diabetes in this country.
Thank you, Mr. Thibeault, and thanks to all of our witnesses on this panel. It's hard to get time with a panel that's so diverse and large. But Ms. Denise, we very much appreciate you sticking with us to get the technological issues resolved, and appreciate your participation and everyone's participation. So thanks to all. We're going to suspend now until 3:30 to allow these witnesses to take their leave and the next ones to get in. So thanks again, and have a good weekend, everyone. We're suspended until 3:30. Call the meeting back to order and welcome our final panel of witnesses. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. See, we have, so joining us for this panel, we have as individuals Dr. Marc-André Gagnon, Associate Professor at the School of Public Policy and Administration at Carleton University, Dr. Stephen Morgan, Professor at the University of British Columbia, appearing by video conference on behalf of Action Canada for Sexual Health and Rights, Dr. Wendy Norman, Public Health Agency of Canada Chair, Family Planning and Research, and from Best Medicines Coalition, John Adams, Board Chair. So we're going to invite you to offer opening statements of 5 minutes in length. But before we do, a reminder that if anyone wants to submit amendments for Bill C-64, the deadline is in 25 minutes, and as was pointed out at the start of the meeting. So we're going to proceed now with opening statements in the order listed on the notice of meeting. So we're going to start with Dr. Gagnon. For 5 minutes, welcome to the committee. Dr. Gagnon, you have the floor.
Merci beaucoup.
Thank you very much. My name is Marc-André Gagnon, and I am a public policy professor at Carleton University. I have been working in the area of pharmaceutical policy for 20 years. I have written over 150 articles, chapters, and reports on this matter, and I have no conflict of interest. I am always horrified by the groveling behavior of governments before pharmaceutical companies and commercial lobbies to the detriment of the Canadian population. Data is clear. A public universal Medicare plan, as recommended by the Hoskins report, will offer better access to drugs for all Canadians, but also it will reduce costs by about 20%. And yet we are not moving forward fully. Only coverage for contraceptives and diabetes medication has been announced. This would continue keeping in place our public-private hybrid model, which on a global scale has become a model of inefficiency and waste. We have our fragmented patchwork system in Canada. It is not equitable, and it is not efficient. It's not consistent, and some think that we can patch it up with new pieces, but no, the real problem is that it is fundamentally a patchwork system. Let us recall that Canada is the only country with universal public health care that does not include medication, as though prescription medication were not an essential part of health care. Our per capita medication costs are the third highest in the world after the US and Germany. And Canada remains among the countries with the highest number of people who cannot get the medication they need for financial reasons, more than 10%. People who are not filling their prescriptions for financial reasons. Now, I've heard today from a number of people with clear conflicts of interest who are proposing a system with mandatory private systems like in Quebec, which is the only place in Canada where the per capita cost is more than Germany's. So in fact, that means that if we were to imitate such a system, we could become the second highest cost location in the world after the States. So this system of coverage has high costs, and also it takes on the costs of high cost medications for the public coverage system. The risks are ending up in the wrong place. This Quebec-style system would increase costs by $5 billion a year and wouldn't actually reduce financial barriers for people who need help as much as we would like. So there would be mandatory private insurance, which wouldn't actually cover risks. These risks would be dumped onto the public coverage system. The idea here would end up having us pay more for an ineffective system. It would make private plans mandatory, undermine our capacity to negotiate lower prices, and end up asking the public system to pay to cover the risks of the private system. this insurance is not even ultimately covering risks. What a remarkable idea. And what we're seeing is that there's an obstacle to creating a universal public system, as the Hoskin report suggests. And the problem is that too many stakeholders, including provincial and territorial governments, are actually benefiting from the current system with opaque prices and confidential discounts. These public plans cannot actually cover the costs, so they shuffle them to other locations in our patchwork system. Look at Repatha, which is a drug for cholesterol. The official price is $6,000 a year, but because of the confidential rebate, it's only 600%. That's a 90% discount. This is ultimately a rebate to the payer. So in Quebec, a so-called insured person under the public system would end up paying a $23 a month deductible and a 33% copay. And so to get Repatha, they'll have to pay $1,200 a year out of pocket. And all of this for a drug which is only costing $600 a year. And in order to be insured in such a way, the patient will actually be paying a surplus of $731 a year. This is not insurance, this is a ripoff. Meanwhile, the private plans are ending up having to pay for the same drug, not at the government's negotiated price of $605 a year. They're ending up shelling out the full cost, $6,046 a year, because they don't get the confidential discount. This is an institutionalized ripoff. It's unacceptable. People are filling their pockets and have a great deal of interest in opposing any change to this wasteful system. We need an effective universal public system to reduce costs for Canadians and not just shuffle off the costs elsewhere in the system, actually passing it off onto patients and workers. We need a system with the necessary institutional capacity to ensure that we're getting our money's worth. And in order to promote good prescribing habits based on data, not on big pharma's marketing campaigns. We need a rational system as proposed in the Hoskins report. A report which, by the way, the Trudeau government said it would follow. I'll be happy to answer any questions.
Dr. Gagnon, next, Dr. Morgan, please. Online. Welcome to the committee, Dr. Morgan. You have the floor.
Thank you. I'm an economist and professor of healthcare policy who has studied pharmacare systems for 30 years. I've published over 150 peer-reviewed research papers on related topics, and I serve on the World Health Organization's Technical Advisory Group on Pricing Policies for Medicines. I have no financial ties to commercial interests in this sector, nor do I have financial ties with health professionals, unions, or other groups who also take an active interest in this file. I am here simply because I wish to help Canada to develop the institutional capacity that is necessary to fairly and efficiently provide access to necessary medicines in a very complex sector that involves some of the world's most powerful corporate interests and very serious, truly global challenges regarding the reasonableness and transparency of pricing. I want to start by saying that we do not need another study of whether or how Canada should implement a national pharmacare program. Those questions have been thoroughly investigated by 4 separate inquiries since the mid-1990s. All of these inquiries have recommended that carefully selected medically necessary prescription drugs be included in Canada's universal single-payer public health insurance system. The latest of these studies, the June 2019 report of the Advisory Council on the Implementation of National Pharmacare, was conducted by a council of experts from across the country, chaired by Ontario's former health minister, Dr. Eric Hoskins. The Hoskins Council, as it is known, consulted with provinces and territories. They consulted with First Nations. They consulted with patients and health professionals and other stakeholders in the sector. And they consulted with Canadians from coast to coast. They concluded with a detailed and feasible plan for implementing a universal single-payer public pharmacare program that would save Canadians billions of dollars every year while improving access to medicines from coast to coast and reducing strains on our healthcare system. So the foundations of Bill C-64 are backed by thorough discussion and analysis. And I believe C-64 can, if the government actually wishes to do so, move us toward the fair and efficient pharmacare system that has been recommended by commissions time and time again. But as it is written, C-64 will not do this. This is because it does not make it absolutely clear what type of pharmacare program the bill would establish. This ambiguity in C-64 allowed the Parliamentary Budget Officer to conclude that the system that would be created would be a fill-the-gaps pharmacare system involving a patchwork of literally thousands of private and public drug plans. Indeed, even the Minister of Health testified yesterday that he would create such a program with the powers that C-64 would give him. This would be disastrous for Canada because patchwork pharmacare systems inject needless and costly inefficiencies into the system. They impose significant inequitable financial burdens on individual households and employers. They diminish a country's purchasing power on the global market for pharmaceuticals, and they isolate the management of medicines from other key components of the healthcare system. It would be especially problematic to have for-profit insurers involved in the core of a national pharmacare system. This is something that only the United States permits. It is problematic because insurers can actually profit from higher drug prices through higher administrative fees charged to plan sponsors. They can also profit by pocketing secret price rebates that they can and do negotiate with drug manufacturers and pharmacies. If the first stage of national pharmacare is allowed to be a fill-the-gaps program involving a mix of private and public and for-profit and not-for-profit insurers, subsequent stages of national pharmacare will almost certainly be locked into that model too. If, contrary to the recommendations of its own advisory council on the topic, the government wishes to implement a fill-the-gap system, it can leave C-64 as it is because that is what this legislation will deliver. In that case, the NDP should understand that their supply and confidence agreement has been broken. If, on the other hand, the government does indeed wish to implement the recommendations of its own advisory council on this topic, then it must amend C-64 to set out crystal clear standards for a national program that will prove that Canadians are, in fact, stronger together. That is what Canadians deserve, but as the bill is currently written, that is not what C-64 will deliver. Thank you.
Thank you, Dr. Morgan. Next, Action Canada for Sexual Health and Rights, Dr. Wendy Norman. Dr. Norman, welcome to the committee. You have the floor.
Thank you, Honourable Mr. Chair, members of the committee. Thank you for the opportunity to speak today to your study of Bill C-64. I am a family doctor and a UBC professor and have had the honour to have served for the past decade with the Public Health Agency of Canada as the chair for Canada for Family Planning Research. I'm the co-chair on Statistics Canada's expert committee for sexual and reproductive health and have worked with Health Canada to advance several of the programs within the sexual and reproductive health themes over these past several years. And is a long-time collaborator with Action Canada of Sexual Health and Rights. There's 2 points I hope to bring expertise and experience to highlight for you today. First, universal access to free contraception to prevent unintended pregnancy will support immediate, lifelong, and intergenerational impacts for individuals, families, and society as a whole that improve health and health equity throughout Canada. Secondly, our modelling in Canada and examples in practice across the globe indicate that universal, comprehensive, single-payer, first dollar coverage of contraception is required to address the needs of people at risk for unintended pregnancy. In Canada, 40% of pregnancies are unintended, and contrary to what you might expect, most unintended pregnancies result in unplanned births. The devastation of facing an unintended pregnancy and managing whatever outcome can have lifelong and intergenerational consequences, not only for that pregnant person and their partner, but for the unplanned children and for children and other relatives already in the home. The most comprehensive, most effective contraceptive methods have the highest upfront costs. The least expensive contraception has the highest rates of unintended pregnancy. In the case of longer-acting contraception, such as implants and intrauterine devices, are most effective methods. The cost can be over $400 up front For many, this need for contraception conflicts with money that they need for rent or food. Due to their much higher effectiveness to prevent unintended pregnancy, however, those same most expensive methods have the lowest overall cost for a government. More effective contraceptive methods offer families a better and safer start for their planned and appropriately spaced children, while supporting family members to pursue advanced education, to better their opportunities to contribute to the workforce, to our economy, and to service in their communities. In contrast, people unable to afford to manage their own fertility face lower educational achievements, lower household income, higher exposure to intimate partner violence, and their children in turn suffer lower rates of food safety, adequate shelter, and rates of graduation from high school. Through a Canadian Institutes of Health Research funded UBC-led study from 2015 to 19, the Government of BC, Action Canada, and a wide range of our collaborators modeled the cost effectiveness for prescription coverage in BC. We found among people who experienced unintended pregnancy and sought abortion, only about 30% had access to any form of subsidy for contraception, and that contraception cost was the factor most related to those subsequent unintended pregnancies. For over 2 years, we worked with the BC government on variations of patchwork contraception coverage and comparing it to comprehensive coverage through the modeling process. We looked at all kinds of models to address specific gaps. In every case, as soon as we moved from universal comprehensive first dollar single payer systems, the rates of unintended pregnancy went up and the overall health system costs went up. With a model of universal coverage, the BC government most effectively reduces unintended pregnancy while lowering overall health system costs by over $5 for each resident of the province each year. Evidence from health systems around the world indicate that universal first-payer prescription subsidy, rather than partial fill the gaps, is required to support health equity. Analysis after the institution of the U.S. Affordable Care Act determined a savings of over $7 for each dollar invested in contraception and contraception counselling. Similarly, Public Health England has found they're saving £9 for each pound they spend on universal prescription contraception. And an important factor here is that contraception is a stigmatized prescription. This is particularly among equity-deserving populations and those in our society who face the most intersectional barriers. Our study had found that reproductive-age people, and particularly women at the ages of highest fertility, are the least likely to have stable full-time jobs providing prescription benefits. In fact, we found that in analyzing the impact of the new BC policy for free contraception, prior to the institution, 40% of those who did buy contraception had to pay out of pocket completely, and another 20% had private coverage which required top-up payments, co-payments by them. And this isn't even looking at all of the people who weren't able to access contraception because of cost altogether. Once BC implemented their policy, this out-of-pocket costs decreased to fewer than 10% of those accessing contraception. We know that among those...
Dr. Norman, if I could get you to wrap up, you'll have lots of time to elaborate in questions and answers. But
yeah. Thank you.
Thank you.
Just to say then, adolescents and people where insurance is held by a parent or a coercive partner are in a particularly difficult situation and much less likely to access coverage if they need it. So there are few investments in health that have the potential to offer both health system savings and improved equity and health equity for children and families. Bill C-64 would support improved health for the people throughout Canada. I apologize.
Thank you,
Mr. Chair, for going over time.
Next, Mr. Adams, John Adams, on behalf of Best Medicines Coalition. Welcome, Mr. Adams. I know you've been in the room. You know the drill. You have the floor.
Mr. Chair and Health Committee members, thank you for the invitation to be a witness at these historic hearings regarding pharmacare for Canadians. Our Best Medicines Coalition represents 30 patient organizations from Parkinson's, arthritis, hemophilia, and blindness to cancers and other complicated and rare diseases. Together, we represent the interests of millions of patients and their caregivers. I'm happy to have moral support from J.K. Harris of the Canadian Breast Cancer Network, and one of our member organizations who's here today. Thank you very much, J.K., for being here. BMC's aims are simple. Number one, fix the postal code lottery by ensuring all patients have access to the medicines they need, the medically necessary medicines, and ensure patients are meaningful participants in the development and oversight of pharmacare policies. First, we at BMC recognize Canada is the only developed nation with a universal health insurance system that does not include universal coverage for prescription drugs used outside hospitals. This gap results in disparities within and among provinces, territories, and Indigenous jurisdictions where individual programs provide varying levels of drug coverage. This is what we call the postal code lottery. As a result, 1 in 10 Canadians reportedly do not take their prescribed medications due to out-of-pocket costs, highlighting significant inequities in access to necessary medications. Up to 7.5 million citizens, 1 in 5 Canadians, either don't have prescription drug insurance or have inadequate insurance to cover their medication needs, or do not enroll when eligible. But cost and coverage aren't the only problems. Here's the bad news for anyone in the Ottawa bubble. 64% of Canadians believe that the federal government is not transparent enough about its healthcare policies. This lack of transparency erodes public trust and hinders the effective implementation and uptake of health initiatives. Then there's data. Inconsistent reporting and lack of transparency in health data hinder the measurement of performance and outcomes, decrease opportunities of identifying gaps in data and services, and impede the capacity of the health system to integrate patient voices. There's also a lack of representation of patient voices within governments and government-funded organizations generating and implementing drug policy. One result is a healthcare system less responsive to patient needs. This can potentially compromise the quality of care and lead to a disconnect between patient expectations and the care provided. In addition, existing complicated patient pathways cause significant stress and anxiety for patients and their caregivers, potentially exacerbating health conditions and leading to worse health outcomes. 30% of Canadians experience difficulties in navigating the existing healthcare system, leading to significant delays in receiving necessary medical attention. Changes in pharmacare must not create new barriers to innovations to address unmet needs of patients. The involvement of patients should be done in more than an expedited and truncated consultation on such a foundational expansion of the social safety net of Canadians. Patients should be built into the programs in the structure, not just an occasional consultation. For example, patients, and that's plural, should be on the board of the Canadian Drug Agency. While we have 8 friendly recommendations for amendments to the bill, as a courtesy, I'm right at the clock of almost 4 o'clock, I think. If somebody could do us a courtesy, we'd love to have those 8 submitted. But I want to, and it's in our written submission, I want to highlight on 2 key points of patient interests. First, create a chief patient officer at Health Canada. And second, create a patient ombudsman who reports directly to Parliament. Only MPs and senators can make this ombudsman role come to life. The chief patient officer at Health Canada would work within the organization. It should be someone with lived experience whose role gives them authority to ensure the patient experience and expertise is recognized and used to drive reform and improve patient outcomes. This person should further be supported by an advisory committee with diverse patient representation, which this legislation doesn't quite contemplate yet. The patient ombudsman would work outside the organization and report independently to Parliament. Besides reporting on any failures to uphold the Act and regulations, this ombudsman would also assess barriers and concerns as expressed by patients when it comes to accessing medications and recommend changes. These amendments to Bill C-64 would enable and reinforce transparency and accountability It's not enough for any government to say they want universal access to medications. Bill C-64 should speak to the role patients must take in improving equitable access to medications. With your questions, I'd be pleased to go into detail on all 8 of those proposed amendments we suggest to better support patients. The Best Medicines Coalition calls on Parliament to do its best for Canada's patients. On behalf of all patients, nothing about us without us. Thank you.
Thank you, Mr. Adams. We'll now begin with rounds of questions, starting with Dr. Ellis for 6 minutes.
Thank you very much, Chair, and thank you, everyone, for being here. It's certainly with interest that we'll pursue this next round of questioning. Without wanting to start a fight with Dr. Gagnon and Dr. Morgan, because you know, both of your bios say that you're Canada's leading experts in pharmacare systems. So it's a good thing you're both not in the room. It might be interesting. But anyway, that being said, I'll start with you, Dr. Morgan. You've written 150 papers about pharmacare and how to implement it. I'm interested to know how much consultative time you spent with the government on this Bill C-64.
I was not directly involved in developing this piece of legislation or the bill at all. So I've worked with government, advised different people within the bureaucracy and government over many years, but I was not involved in drafting Bill C-64.
Thank you for that. And through you, Chair, Dr. Gagnon, were you involved in the drafting of C-64?
Absolutely not.
Okay, well, we've got 2 Canadian experts who had nothing to do with this. This scares me. So that being said, Dr. Gagnon, you talked about the universal healthcare system and a universal pharmacare system. Now, I was a family doctor for a long time. You know, the Canadian Medical Association president a couple of years ago, Dr. Catherine Smart, said that the universal healthcare system is on the brink of collapse. So clearly we have a system that, for a whole host of reasons, is not working. It's not managing well. It's not being managed well. Why would we want to enter into a universal pharmacare system? Again, I'll even put myself in the same boat, whether I should. It wouldn't matter if it was a conservative government or a liberal government. Why should we trust the federal government to make another system that, in my mind, is probably just going to fail Canadians?
So when it comes to implementing universal pharmacare, it doesn't have to be for the federal government to do this. That can be done at the provincial level. That can be done through specific agencies that are being put in place for this, through different type of social insurance systems. So you can have an independent agency taking care of this. But with the current fragmented system where there's no objectives, common objectives, massive waste, we have right now 100 different public drug programs. We have more than 100,000 private drug programs going in every direction, and you end up with a system that if you want to navigate and play the game, basically, doors are very much open for abuse, and this is what we're seeing a lot. So when it comes to cleaning up what's happening, a universal single-payer public system remains the best thing to do. Then you can have all the other players adding up with supplementary coverage, be it provinces being private payers. It's not an issue, but we need a solid foundation that works well, that is efficient, that works rationally, that gets us value for money, that also promotes a more appropriate use of medicine. And if we have these building blocks, then we can see, in terms of in French we say la finition. Then we see basically what we add up over this, and we can build different things. But we need the solid foundation. It's not there right now, and we are not prepared with, for example, all these new super expensive drugs coming to the market. We are not prepared to face the music. Canadians are not prepared because we don't have these foundations now.
Thank you very much. And Dr. Morgan, I'll turn to you. The other thing that it appears is often, we've heard in the last couple of days testimony related to the length of time it takes a medication to get on formularies on behalf of Canadians, often thousands of days. We've got the Health Canada, PMPRB, CDA, CADA, PCPA, et cetera, et cetera. It would appear to me that it would have been also a good idea in this Bill C-64 to add some oversight of those agencies, specifically the newly formed CDA. Do you think that would be benefit here, or do you have some other ideas around the necessity to get drugs to market on behalf of Canadians?
A couple points. I'm glad you raised the issue around timeliness in terms of drug approvals and coverage decisions. Some of the evidence that's been cited in testimony in these hearings is concerning or from reports that start the clock, so to speak, when a medicine is first approved in any country internationally. So it doesn't take into account the fact that manufacturers themselves choose to delay the introduction of a drug into some markets for strategic purposes, but also because often they'll trial drugs in markets like the United States, Germany, or Japan, and then choose whether ever to even launch in other markets. Nearly half of all drugs that are trialed in that way don't make it to other markets, so that's important to know. As far as delays in approval times, I think there are concerns about making sure that Health Canada is adequately staffed and resources to make its timelines. There's also concerns about the fact that the fragmented system we have right now with CADF and the PCPA and then provincial decision making that follows it is one that does beget long delays in coverage decision making. And in fact, in that process, it is one of these processes that no means no in terms of the recommendations from the advisory bodies, but yes only means maybe, because provinces are not bound to complete the coverage equation. So a truly national program that is managed by an agency such as the Canadian Drug Agency or something like that was given the budget to manage and the task of making sure that there was timely access would be a system that would make sure that we don't have those kinds of delays.
Thank you.
It should be reasonably independent, but it should be accountable for performance.
Thank you, Dr. Morgan. Next, Mr. Nakvi, please, for 6 minutes.
Thank you very much, Chair. And I'll start my line of questioning with Dr. Morgan and Dr. Gagnon. You both are experts in pharmacare. You've studied this. Can you talk about the impact of the lack of a pharmacare plan on the general health of a population? And we can talk about Canada. What's the impact in terms? I'm assuming is negative, and if it's negative, in what ways does it manifest itself? Perhaps we can start with Dr. Gagnon, with you first.
That's an excellent question, and basically, lack of access is a very important issue. And low-income workers are normally the most impacted by this. Racialized communities in particular, based on surveys that were made looking at barriers to access, looking at issues of race, racialized communities was a big problem. What we see a lot, and this is something super important when we do all the budget and costing and stuff, because the PBO, something they did not include in all the costing, is how much money we would be saving in hospitals, in emergency rooms, if people can have the right access to the drugs they need. So keep in mind that the PBO report showed that we would be saving more than $2 billion a year, but also by extending by 13.5%. We will be increasing basically the amount of prescriptions by 13.5%. So this is 13.5% of people who need prescriptions right now and are not getting it. They are the people who end up in emergency rooms. And then this is for hospitals, because if you go to the hospital, then it's not the same budget. Your drugs are being paid for by the hospital. Other issues that for me is also very important when it comes to Social Security. It's just you know, if I'm in Quebec, I'm on Social Security, I will be gaining something like more or less $15,000 a year. If I try to go to work and start working, let's say 15 hours a week because that's all I can do, you know, I get access to my drugs with no premiums, nothing to pay, everything for free as long as I'm on social assistance. As soon as I want to get out of this, basically, then I need to pay huge premiums in Quebec. You need to pay your full premiums even if you're only working part-time. And if you're working only 15 hours a week, basically you end up with maybe $20,000 in terms of revenues, but then something like maybe $2,000 a year in premiums for your prescription drugs. And in terms of creating poverty traps, you know, Munir Sheikh, when we wrote this report about the reform of social assistance in Ontario, meeting with people, that was one of the huge barrier, the huge poverty trap. Basically, people end up with trying to stay in programs where they can have access to their drugs, because if you switch to at different stages, you might lose access and basically impact on your health, so morbidity and mortality. And maybe one last point on diabetes. You know, there was a study 10 years ago basically showing if in Ontario only we had universal single-payer first dollar coverage for people with diabetes, basically that would save 700 lives a year. And this is amazing how much we're not doing anything about this, because it's not two planes that fall down on the street and everybody dying. It's just, oh, well, these are statistics somewhere. 700 people, they were sick anyway. This is not important. This is freaking important. So yes, these are some of the issues.
Thank you, and I appreciate your passion. Dr. Morgan, do you have anything to add to Dr. Gagnon? Any additional points?
No, other than to say this has been thoroughly studied, and the business case for making sure we have universal access to appropriately prescribed medications is unequivocal. It is good for the country's health. It's good for the healthcare system.
I want to come to Dr. Norman. Thank you for being here and bringing the perspective of Action Canada to this conversation. And on the same theme of cost savings in the healthcare system, can you talk about what kind of impact we can see from having universal access to contraceptives that's contemplated in Bill C-64?
Absolutely. Thank you for the question, and through the chair. As a family doctor who's been working in family planning for most of my professional life, I see regularly people coming in for recurrent unintended pregnancies where they do not want to be pregnant, they hadn't wanted to be pregnant, and they have no access to the ability to be able to manage their lives so that they can continue in their education or get out of a toxic relationship, or to be able to undertake the job training to move into a profession that they would like. And they're saddled again with an unintended pregnancy. Some of them will go on to ensure that they aren't pregnant through to delivery, but most will end up having to look after other children and then have childcare and other actions in their homes that make that take the time of their lives that they could have been using to advance the care for the children that they already have and for themselves and their lives. So I think when we talk about cost savings, we can show, and all over the world systems have shown, that single-payer, first dollar universal contraception coverage will be able to have better health outcomes and lower pregnancy care costs. But I think we have to look as well at the costs to our next generation and to the fact that they will have lower achievements throughout their lives due to the inability of their parents to have accessed universal contraception.
Thank you, Dr.
So that
Moore.
it becomes intergenerational.
Thank you, Dr. Norman. Monsieur Blanchette-Chonka, pour 6 minutes, s'il vous plaît.
Merci, Monsieur le Président. Je salue les...
Thank you very much. I'd like to thank the witnesses on the third panel. My first question is for Mr. Adams from the Best Medicines Coalition. in the recommendation 6, you said that the Minister of Health should create a special access path for patients so that they can receive prescriptions under specific circumstances of drugs that are not on the list. As you know, in Quebec, we do have a program that will pay for certain medications under exceptional circumstances. An example is, as a final attempt, what would be your recommendations on this matter?
Excusez-moi, je parle bien long, seulement un petit peu. I will do this in English. We've heard a lot about Quebec today in the conversation, and thank you very much for the question because it highlights one distinct aspect of Quebec which the rest of Canada should emulate. There will always be, the other thing we've heard a lot about, not every patient responds in the same way to the same drug. So we need some variety and some choice in that. And Quebec has a mechanism where a doctor can apply to a truly independent scientific review committee that is outside of the health bureaucracy for a drug that the doctor knows the patient needs, whether or not it's been approved by Health Canada, whether or not it's being funded through the existing system. And I come from a rare disease community, PKU, phenylketonuria. It's not life-threatening. It's only brain-threatening. I have a son with it who's a responder to the first pharmaceutical and a true and a full responder. Every patient with PKU who's gotten access to that the first drug for PKU has been approved through Quebec's unique, exceptional patient program. There will always be outliers. What we need to achieve, working toward, is precision medicine, a molecule that works for the individual given that individual's genetics and biochemistry. We're not all the same. One size does not fit all. And it would be a great improvement for national pharmacare as a concept to always have that safety valve for the exceptional patient. And there's decades of working experience in the province of Quebec that we can all learn valuable lessons from.
Merci, M. Adams. Écoutez, j'apprécie.
Thank you very much, and I'm glad you recognize that distinction because I think you know that it's not just when it comes to Medicare. We could probably carry out another study just on that topic, but perhaps that wouldn't happen at the Health Committee, maybe at some later time. Now, coming back to what you mentioned in your brief, you said that no patient in Canada should lose coverage because of reforms in C64, and that these changes should not leave patients in a more precarious situation than before the reforms. Could you please explain your concerns?
We hear many concerns and criticisms of the model proposed in the version proposed in Bill C-64. I've heard additional criticisms from my fellow panelists today. And we're hearing mixed messages about whether this is such a good idea or not as proposed. I, as the parent of 2 sons and 2 daughters, I care about sexual reproduction and sexual health all the way around. And as I used to be pre-diabetic, I no longer am. So I care about medicines for diabetes. The drug that turned me from a pre-diabetic into non is not on the list as proposed by the Minister of Health at the moment. So those are specific examples. There's a great deal of uncertainty. And also, there have been, in previous government initiatives, at federal and provincial, territorial, and Indigenous levels, there have been unanticipated or unintended consequences. And make haste slowly. I think the bill is a useful start, but I think this legislation is in need of and has many opportunities to be improved.
Monsieur Adams, vous mentionnez toujours dans votre mémoire une chose très importante.
You also mentioned something else very important, saying that the federal, provincial, municipal, and indigenous governments should all work together and consult stakeholders. We must place emphasis on effective, simplified infrastructure in order to improve patient care with a high level of fairness and a wide scope of medication available to everyone in a timely fashion. I completely agree with this. You have said that everyone needs to get the best possible care. With that in mind, don't you feel that the federal government should increase the health transfers to enable Quebec and the provinces to improve their healthcare systems and thus improve patient care?
Brief response, if you can, please, Mr. Adams.
I'm old enough to remember when Medicare was sold to Canadians and to provinces and territories on the general concept of a 50-50 cost sharing. We should take a look at that. All right.
Thank you, sir. Ms. Zarillo, please, for 6 minutes.
Thank you so much, Chair. And I just wanted to get some clarity from you before I begin my questioning. You mentioned that the time for amendments was a while ago, so just wanted to clarify that any input that comes today will not be able to inform an amendment. Is that correct? Yes.
That's correct.
Okay. So I just want to say what an amazing panel this has been, and so informative. And because it's not at this time able to have technical influence on the bill, I do have some questions just around equity and fairness, and I really want to focus on gender equity, because I think that if there had been more women in the government at the federal level, we would be a lot further along, certainly on contraceptive. So, Dr. Norman, I just wanted to ask specifically about getting results. So we know that BC, and you mentioned it, has free contraceptive now, and I'm wondering if you could share some of the arguments or factors that got the BC government to implement free contraceptive, because obviously it's something that I would like to see and many people would like to see right across the country.
Thank you very much, Member Zarillo, for your question, and through the chair. We were funded by CIHR to conduct a study where the Government of BC and the Ministry of Health were one of the partners in setting the research questions on the main research question and how to analyze the results so that we would be able to support them for what would be the impact of a system of subsidy for contraception on health and equity in BC. And so our study undertook, first off, a province-wide sexual and reproductive health survey, and this government in 2021 was able to use the basis that we made for that sexual and reproductive health survey to implement a sexual and reproductive health survey across Canada that we'll be fielding later this year, run by Statistics Canada. And I think that this is a key moving forward as we implement free contraception through this bill, in my hopeful way, to be able to measure the impact, because this was what BC used to measure the need. And this was how we determined where there were inequities and how those inequities could be addressed through universal contraception. So undertaking surveys of people and being able to look at health system and health administrative data in comparison with the survey data, and StatScan's new survey that will go out will also be linking with a personal health number to health administrative data, so that we'll get specific disaggregated equity data on the gaps for people in achieving their sexual and reproductive health. The baseline in 2024, of course, will be before any impact of this bill, but I think it will be very important moving forward for the government to continue to have, as one of Statistics Canada's core surveys, a sexual and reproductive health survey that allows us to disaggregate and understand those equity barriers across Canada. I don't know if I've answered your question in the way you
have, and it's spurred on another question. And I mean, you've been working in reproductive health for a very, very long time, so I'm sure you have some indication of how those surveys are going to come back. But my question is around what factors do you think contribute to the difference in prescription insurance coverage described for the population overall and for those at risk of unintended pregnancy? Because I'm quite sure that you're going to get information about the disaggregated groups that have unintended pregnancy.
Yes, absolutely. Well, as you have heard from other panels here today, I'm hearing that experts in the insurance industry say 97% of people have some form of coverage. Well, we certainly are not seeing that in sexual and reproductive health. When our studies have looked at those presenting with unintended pregnancies, we find that up to 70% have no coverage at all. And when we've been able to look overall at the prescriptions accessed in BC through the pharmacy for people who have already accessed and purchased a contraceptive, 40% had complete out-of-pocket payment for that with no insurance whatsoever, and another 20% required a copay. This copay and not having insurance for that 60% of those accessing contraception doesn't even illuminate for us the wide range of people who weren't able to access contraception at all because of that inequity of cost. The people who need contraception tend to be those in the reproductive age range and the age of the highest fertility among women and people of any gender who are pregnancy capable. This age range doesn't have has one of the lowest rates of permanent jobs, of full-time jobs that offer coverage. There's a gig economy, people still in school, and the coverage through people of this sector of highest fertility has often is through a primary plan holder for coverage where they might have it, who has power over this person. And so they need to disclose their use of contraception is a barrier for people in coercive relationships, for adolescents on parents' plans.
I'm just going to interrupt you there because I want you to go on that one a little bit. So, I mean, I'm a female, and like many people, by the time you're 16, you're having conversations about having contraceptive and needing contraceptive. And I did make note of your questions or your comments about parents or coercive partners. Maybe you could share the risk that presents to teens and young, very young females in regards to that.
Yes. So as many of you are aware, the highest fertility rates are at the closest time to your teens and decline after the late 20s. In this age range, people are often still living at home, or if they are away from home, they're often in relationships, sometimes with a partner who is the person controlling their access to contraception or to funds. These individuals are facing so many intersecting barriers to achieve their own gender equality. They have to choose between buying a contraception or paying their tuition or rent or food. Clearly, the other three aspects are their first priorities so that they can continue on in their lives. And they'll use no contraception or a much less expensive method that has high pregnancy rates and present then with an unintended pregnancy that may stop their education altogether.
Thank you, Dr.
Prevent
Norman.
them from going into the workforce.
Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. It's greatly appreciated being it late on a Friday. And although our windows are closed, I have no idea what the weather is outside, but I appreciate you all being here at this point in time and your presentations and comments. And as you all understand, ultimately we're looking at the legislation, and to me and to you, I believe, is that what can we do to make this piece of legislation better? What steps can you put forward and suggestions that we should be able to utilize, that we can make amendments if needed to this? And that's a huge challenge because as we've heard, those amendments have had to be in by 4 o'clock today, and so there's concerns as to whether they actually were put forward and will they even be passed or not. It's time will tell along those lines. But one of the things that I think is being sort of alluded to, but not really hit on, the fact that healthcare is provincial. It's been touched on by a number of you that it is a provincial issue, and it comes to that aspect of the provinces being able to do what they need to do. And so my first question, to you, Dr. Gagnon, and you made some comments on looking at steps that could be done. And you did indicate, or suggest at least what I thought I heard you say, it could be done by at the provincial level. I'm just wondering, are you suggesting that we as federal government should be putting in legislation to tell the provinces that they should be putting in a universal health care plan?
Certainly, having some help from the federal government to implement this would be something that would make things way easier, I think, for provinces. You say healthcare is a provincial jurisdiction. I don't want to get into the legal stuff, but constitutionally, healthcare establishments are of provincial jurisdiction. When it comes to prescription drugs, this is more complicated because this is outside healthcare establishments. That's one thing. When it comes to drug approval, so this is the criminal law in terms of determining which substance is illegal versus legal, and if it's legal, what are the ways to have some access to it, so with the pharmacies and everything. So this is why we have Health Canada basically approving the drugs. And at the same time, when it comes to the pricing of these drugs, this is based on the Patent Act, which is also at the federal level. So like it or not, when it comes to prescription drugs, the federal government already has 2 feet basically in this field. It doesn't mean that the provinces shouldn't have nothing to say about this. I'm a proud Québécois. I think and when we put in place our pharmacare system in 1997, at the time, basically, it was perceived as a first step towards universal pharmacare. But what we put in place as a hybrid system, we kind of locked in all these commercial interests, basically, who can abuse the system in different ways. This is not normal that in Quebec, we are the 2nd place on this planet with the lowest cost, the highest cost per capita when it comes to prescription drugs. And that nothing is being done about it except, instead of containing costs, we'll just shift the cost elsewhere in the system.
I appreciate it, and I apologize for everything because I have such limited time. I appreciate that comment, but ultimately it still comes down to the provinces that need to make those decisions on what they believe, as Quebec has done, and every other province should be doing, which is what's best for them and their provinces. Mr. Adams, I appreciate what you presented and your recommendations and your 8 recommendations that you put forward. I think there's some good things about it. And ultimately, when we look at the legislation, the amendments, because we're dealing with this little piece that we have right now, the scary part is, will that grow over time? And ultimately, one of your recommendations that you did make, and I think in some ways it relates to what's talked about within, for particularly the National Formulary, when we talk about the Canadian Drug Agency. And one of your recommendations, and I'll just read it to you, the Canadian Drug Agency must be established in legislation rather than at the direction of the Minister of Health, and subject to parliamentary oversight, the Access to Information Act, Auditor General scrutiny, and interventions by a patient ombudsman. And those are recommendations that are suggesting, in many ways, in particular for this agency, but also through what we've seen in the legislation where we talk about building committee, but we have no idea who those people will be on those those roles. I'm just wondering if you could comment on that.
Briefly, please, Mr. Adams.
Thank you. And I don't know if there's procedurally any way to get an extension to 5 o'clock for those amendment guidelines. I toss that out there for what it's worth. This bill gives the minister substantial new powers. It could be improved by building in various forms of transparency and accountability, as I've said. And those were some of the things. And with all due respect, I think it defers too much to the black box called the Canadian Drug Agency and doesn't put transparency or accountability mechanisms around what could become a very important role in system reform. All right, so that's the plea.
Thank you.
You're members of Parliament. Don't cut yourselves out of accountability and transparency. Build it into this legislation by amendment. Thank you very much.
Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being with us, and thank you your amendments and submissions, submitting to the committee. Thank you, and for your work. My question is to Dr. Norman, mostly question to you, because first of all, are you able to speak about the BC, the program, which it's a successful program? You have any data to share with us? I know it's a successful program. Can you share the data?
Thank you, members. Sidhu, and through the chair, for a great question. I'm very proud of the work that we've been doing with the government of BC over the last 10 years to build towards this program. And I am working within the ministry under a non-disclosure agreement to assist the ministry to evaluate the implementation of the program. I have access as well to independent research we've been conducting at UBC on health administrative data. So I can share with you things that we've found on our own, but not the wonderful, amazing things that we're finding within the government in our own evaluation. So what we can see from the health administrative data access that we have through the university is that we have thousands of people requesting these new contraceptives and the most highly effective contraceptives since the policy was brought in place about a year ago in BC, thousands every month. In fact, we had such a surge and a sustained request for these most effective contraceptive methods that have been out of reach for people in their personal and household economy before this, that the BC media has been reporting on the wait lists and on the health system and service factors that now are being addressed to be able to meet this unmet need. But I think it's a very, when you can see, even the media can notice that there was such a high degree of unmet need in the province that the rush of people to access intrauterine devices and contraceptive implants, this matchstick size device that people can put in their arm has a lower rate of pregnancy than tubal sterilization, and yet it can be removed at any time and it can last for up to 3 years. People are rushing to be able to get these more effective methods that we've had before, rather than rates for birth control pills that might have nearly 100 times as many people pregnant each year than these more highly effective methods. So yes, BC has been a success story. We are super excited about the numbers that we're seeing from the comprehensive data within the government, and even from the data available in media reports and through the publicly accessible data we can access BC through UBC. It's a out-and-out success story. This is a way that people are now meeting their needs to be able to stay in school, to contribute to the workforce, to realize their own dreams for whether and when to have children and how to space them.
And Dr. Norman, what recommendation can you give to this committee on the education component during the implementation? How can we work with the provinces, territories, and Indigenous group on working with the young women, girls, their families, and potentially schools on raising awareness about the program? You talked about contraceptive stigmatization, and yesterday we heard about the teen pregnancy. So can you talk about that?
Thank you. This is a wonderful question, and I think it's a piece of the puzzle that we all need to pay attention to. I think, again, I would come back to the need across Canada for a comprehensive national sexual health survey that's iteratively and regularly administered so that we can disaggregate and understand where we can target education programs, where we can target outreach health systems that can get to those populations that inequitably aren't able to understand the knowledge, the methods, the services that they require to achieve their own reproductive health goals. And the ability to address a problem first needs us to understand it. And to understand it, we need to measure it. And I think the baseline sexual health survey that will go out this year will provide a lot of data for the government on where we could be going, but it won't help us to understand how this bill and other future efforts that the government has made, the amazing work that the government's been doing to advance sexual and reproductive health through Health Canada, these impacts need to be measured as we go forward.
Thank you. Monsieur Blanchette, Jean-Car, pour 2 minutes et demie.
2.5 minutes, please. Thank you. I have more questions for Mr. Adams. Earlier today, some witnesses mentioned that we need to be careful because the expert committee will not simply have we need to ensure that it doesn't simply have a rubber stamp role. We need to ensure that they get appropriate information to give real advice and not simply act as an echo chamber or rubber stamp previously taken decisions. Do you agree? What are your thoughts?
We had many lessons recently from a little thing called a pandemic. And some of us took the time to observe the advisory processes in another jurisdiction south of Canada. And when the CDC and the FDA advisory committees were whether they were dealing with vaccines, whether they were dealing with therapeutics, other things, they would have those. I could watch those on Zoom, and I could read the background materials. I could come to my own informed view. Did they get it, or did they miss it? When those advisory processes take place inside a black box, and you can't see, I welcome this opportunity. We're in public. People can make their own evaluations whether I get it or not. I can make my evaluation whether you get it or not, because it's open, it's transparent, and we can be accountable. When there's too much of the process at the federal level and at the provincial and territorial levels that take place behind closed doors and black boxes, it's time to, I would appeal to this committee to move amendments to start opening doors and opening windows and let the sun shine in.
28 seconds.
Monsieur Adams.
Mr. Adams, do you have anything particularly important that you'd like to add that we should do in order to make sure it's done right?
We've in our written submission, there are specific things there. I think you need to do your best to ensure that the freedom of information and access to information rules apply to the new model that this bill is trying to build for pharmacare, that there's accountability so that the Auditor General of Canada can go in and do value for money audits, and that there be a new function of an ombudsman, so that people who think the system has not responded to them in a fair and reasonable way have an ability to access, without going to court, have an ability to access a review and oversight function, and that those officers and the health minister are required to report back to Parliament on a regular basis on steps, progress, and problems, and alternatives.
Thank you, Mr. Adams. Ms. Cirillo, for 2.5 minutes, please.
Thank you. So I just wanted to ask Dr. Morgan, Dr. Gagnon, and Mr. Adams each. I only have about 30 seconds for each answer. But outside of this bill, each of you said something that I'm interested to know. Outside of this bill, Dr. Gagnon, you said institutional ripoff. What can we do to fix that outside of this bill? Mr. Adams, you said postal code lottery. What can we do to fix that? And Mr. Morgan, or Dr. Morgan, you said fairness and efficiency. So maybe I could start with Dr. Gagnon.
One example, Trintellix, SSRI antidepressant. So it came to the market, and CADIF at the time basically did the evaluation. There was no clinical evidence that this new drug was bringing anything more as compared to already existing drugs. And the recommendation, do not pay a penny more for this drug than the lowest priced drug of this category. Trintellix still entered the market with a price 10 times what it is for other drugs of the same category. I was reading annual report from the company Lundbeck saying, in Canada, Trintellix, this drug that doesn't have any clinical evidence that show any advantage as compared to other drugs, we did manage to capture 24% of the antidepressant market in Canada. So in terms of ripoff, if we have a system that says, you can make a commercial blockbuster with a drug that doesn't bring anything new, and basically the message you're sending in terms of incentives for innovation is don't innovate. We have a crappy system that will take in anything at any price. And this is what, in terms of institutional ripoff, this is what is missing in terms of getting value for money.
Thank you. Mr. Adams and then Dr. Morgan.
The postal code lottery, I have to give credit where credit's due. It's not my line. It's the line used by the immediate past federal Minister of Health, Mr. Duclos, in March of 2023, when he announced the go forward of the plan for drugs for rare disorders. I was there. It was ad-libbed by the minister. It wasn't in his prepared text. But it captures the essence of some of the inequities in the lists of drugs that are or aren't covered in various jurisdictions. And I think there is a compelling role for the government of Canada and the Parliament of Canada to make financial contributions so that access gets not to the lowest common denominator, but to a much higher common denominator for all patients, no matter where they live, no matter what postal code in Canada they're in.
Thank you. Dr. Morgan, hope you have time there.
No, you don't, but if you can answer very briefly, we'll allow that.
Yeah, I think that what you do is build national capacity to procure with ironclad contracts with manufacturers medicines of proven safety, efficacy, and value. Essentially, we need to implement the recommendations of the Hoskins Council.
Thank you very much, Dr. Morgan. Next, Ms. Roberts, please, for 5 minutes.
Thank you, Mr. Chair. So I'm going to ask yes or no questions to everyone. So I'm going to start with Dr. Gagnon. Do you think family doctors are crucial?
Crucial?
Like they're important to society?
Yes.
And Dr. Norman?
Well, as a family doctor, I think I have to declare my conflict of interest, but I would say
Okay.
a resounding yes.
Okay. Dr. Adams?
Yes, thanks for the promotion. Yes.
Dr. Morgan?
Yes, alongside of other primary care providers.
Okay, so I'll tell you why I'm asking this question is in Ontario, that's the province I'm from, we have 2,500 shortage of doctors. Over 2 million people don't have doctors. And by 2026, it'll be 4.4 million people without a doctor. 1.7 million people in Ontario alone have a family doctor that is over the age of 65. In Canada, 6 million Canadians who don't have a family doctor. And the reason I bring this up is a couple in BC, Jane and Steve Williams, have been on the waiting list for 3 years for a family doctor. He just recently went in for emergency surgery, and he has no family doctor that will be able to help him. So here we are, we're talking about pharmacare, we're talking about, taking care of our patients. How can somebody get the required medical attention and have the drugs prescribed to them that they will need? So I'm going to go back to Dr. Morgan because you made a statement earlier, and I just want to make sure I get this right. You made a statement earlier that this is a patchwork system, and I have to agree with you. I don't think that this system was well thought of, and if I understand correctly, Dr. Norman, you said you were part of the panel. Is that correct? You're part of the pharmacare investigation with the panel with the government? No?
Oh, Norman.
Oh, okay. Sorry. Okay.
No, I wasn't part of the pharmacare panel.
And were you, Dr. Norman?
Part of the panel
to develop the pharmacare plan.
I worked with the BC government to be able to provide evidence that supported their development of their plan for contraception, and at the request
But were you part of the plan federally?
Of the Minister of Health in BC, I was able to present to the Minister of Health federally and other federal departments.
All right.
But I provided evidence. I wasn't part of their internal process to develop the bill.
Okay, so we have experts here that were eliminated from that. I'm a little confused about it. But Dr. Morgan, this patchwork system that you mentioned earlier, I have to also question, how is it that this pharmacare will benefit Canadians?
Well, one of the things is if we move to a system that is truly national, universal, single payer, Canadians will have increased access to medicines from coast to coast. We can use national procurement contracts to get better prices of medicines. We can use those same contracts to make sure that manufacturers guarantee the supply of medicines when Canadians need them and when we know shortages are all too common internationally. And it's true that if the federal government was actually to fund these first stages, contraception and diabetes treatments, and was able to leverage the purchasing power nationally to just get the average price we find in comparative countries, that system might cost actually more than the PBO is estimated, but it would deliver savings to the provinces and territories on the order of about $1.3 billion per year.
Okay,
it would deliver savings to the private sector of $1.7 billion per year, and net savings to the country of $700 million.
Okay, so I'm sorry to cut you off, but I do have limited time. So my concern is Bill C-64, in its current state, does not give specific enough information to ensure that this plan will benefit Canadians. And unless I misunderstood you, that's what I took from your statement.
This plan will provide some new coverage, but it will cost significantly more than it should, and it will continue to impose inequitable financial burdens on individual households and employers.
So would you agree that individuals with private health care and private plans are better off than the current plan that the government's offering?
They're not better. There's no change. That's what the minister basically said yesterday in testimony, that they'll just have the same coverage through their private insurance under this new plan. What we want to see is a change where they can actually see their medicines being procured nationally through a public program that takes the financial burden off their households and their employers.
But right
That's
now,
not what this bill will achieve.
Thank you,
Exactly.
Dr. Morgan. Thank you, Ms. Roberts. And the last round of questions for our examination of Bill C-64 will come from Mr. Joe Harry for the next 5 minutes.
Thank you, Mr. Chair, and I thank all the witnesses for joining us today well into the Friday afternoon. I know it's past 4 o'clock, and most of the amendments probably it's already written down and passed on, but I want to emphasize the fact that this bill will go through clause by clause on Monday. It will be sent back to the House, and we have the opportunity to be able to debate it, and it will go to Senate. And that presents more opportunities for us to be able to highlight areas that we could strengthen it. I'm going to focus most of my questions to Dr. Morgan. I noticed you were patiently waiting, and a number of times you wanted to intervene, and you were not given the opportunity. So I'm going to dedicate all my 5 minutes or so that I have to you. You're very complimentary about Hoskin report, and you also said that if certain elements are considered in the design, then this bill C-64 would be a good starting base for us to introduce, pharmacare. Can you summarize, if I'm getting up on next week in the House and debating on the third reading around those areas and using Hoskin as a base and say, hey, look, this is reality of C64. This is the base in the Hoskin. And these are the three areas that I want to focus to make sure that this bill is strong. What would those three areas be? And you have all the time that you want before the chair stops you.
Yeah, so I'll be quick. There are just minor amendments to sections 4 and 6 of C64 that would probably suffice to make sure that even though this is just like baby steps, the pilot project for implementing Hoskin's recommendations, if you make a couple of key amendments, you can genuinely say that this legislation was actually going to do what Hoskin said. So, for instance, in Section 4 of the Bill C-64, the minister, it says the minister is to consider the following principles. And I think the conservative members of this committee pointed out that that's unusual language. It should say the minister shall apply the following principles. That's important language. On Section 4(1)D, it says shall provide universal coverage of pharmaceuticals, but the Hoskins Council was very clear it should be universal, single-payer, first dollar public coverage. So there's language there that could be improved and clarified. As was discussed yesterday at this committee, this bill should define what is meant by single-payer, first dollar, and public coverage. Those are terms that are very clearly defined in the Canada Health Act, which would be the analogous act to C-64 in terms of establishing principles that all provinces and territories should aspire to in delivering these things. So there's a few changes there. And similarly, in Section 6, when it talks about the kind of coverage that should be implemented, it should be very clear that we're talking about, as the Hoskins Council recommended, and as have many other commissions recommended, the program should be universal, single payer, first dollar, and public. And that word needs to be there.
Okay, thank you. I want to go back to another topic, and I want your input in. So, as it relates to, let's say, diabetes, and as it relates to the different type of diabetes medication, the minister has said this is basically our floor, and we will negotiate with different jurisdiction, provinces, territories, indigenous group, and others, and we look at their needs, and then we'll expand that. What are your thoughts on that?
So if I was to design a program like this, I would start with a sense of what is the most compelling evidence-based basket of medicines that should be provided. And you've heard witnesses testify that some of those compelling medicines, including GLP-1 drugs like Ozempic, are outside of the current proposed basket. So you might go back and think carefully about what would be included. But I want to be clear that if you do this as a truly universal plan, as a truly single-payer plan, buying medicines on behalf of the 40 million Canadians, you would have such purchasing power that you could include a comprehensive basket of treatments for contraception and diabetes and save considerable funding while doing so. So it can be done in a very prudent way, and it should be evidence-based, but also sufficiently well-funded so that it does meet the needs Canadians have.
Thank you. And then my colleague, MP Pawlowski, agrees with you violently as I'm sitting and looking at him. Thank you, Mr. Chair. Thank you very much for the latitude you showed me. Thank you.
Thank you, Mr. Johari, and thank you to all of our witnesses. This was an absolutely fascinating panel, a really, really good one for us to finish on. We are coming up to the time that has been designated by the House for adjournment. Before we adjourn, separate and apart from thanking the panel, we've been very well supported by the clerks and the analysts and the technology people, the IT folks, and the interpreters throughout this process. On behalf of the committee, I'd like to express my gratitude to them. Is it the will of the committee to adjourn the meeting? We're adjourned. Thank you.